How uncomfortable must it be to live in a body that looks powerful on the outside but feels like a constant strain from within? From someone like the great Kali, often seen as a symbol of sheer strength and size, the reality of living with acromegaly is far more complex. What many don't realize is that this is not just about physical appearance, it's a condition rooted deep within the brain. And that brings us to a deeper question. How much can the brain really change a person? In this World Neurosurgery Day special of Rebooting the Brain, we are joined by Air Marshal Dr. M.S. Sridhar, a neurosurgeon whose journey spans the structured world of the Indian Air Force and the high-stakes precision of the operating room. This episode explores how even the smallest brain tumor can profoundly impact behavior, personality, and identity. What may seem like a tiny lesion can completely alter the way a person thinks, feels, and lives. We dive into the realities of brain tumors, the intricacies of brain and spine surgeries, and the critical role neurosurgery plays in understanding and treating pain, not just as a symptom, but as a deeply neurological experience. Dr. Sridhar also shares his journey, what led him to the Air Force and the discipline instilled, and how that foundation shaped his path in neurosurgery. Along the way, we reflect on the legacy of pioneers like Harvey Cushing, whose work continues to influence modern neurosurgery today. From the visible to the invisible, from strength to struggle, from the body to the brain, this is a conversation about precision, responsibility, and the weight of every decision inside the human brain. This is Rebooting the Brain, and this episode is about the brain, pain, and everything in between.
ജ്ഞാനാനന്ദമയം ദേവം നിർമ്മലസ്ഫടികാകൃതിം ആധാരം സർവവിദ്യാനാം ഹയഗ്രീവ ഉപാസ്മഹേ ഹയഗ്രീവ ഉപാസ്മഹേ.
Rebooting the Brain, powered by PRS Neurosciences.
Namaste, everybody. Welcome to one more episode of our podcast, Rebooting the Brain. And as usual, we have a fantastic guest who's going to give you some beautiful pearls on what is going to happen to certain areas of our brain. Before that, I'll start with the Shanti mantra. Om Asatoma Sadgamaya Tamasoma Jyotirgamaya Mrityoma Amritam Gamaya. Om Shanti Shanti Shanti. This prayer has been an inspiration for me from my childhood. And as the prayer says, from ignorance to enlightenment, from darkness to light, and from death to immortality. You can use this anywhere in your life, personal or professional, and gain invaluable insights. Please try it, guys. You will not regret it. So before I introduce the guest of the day, some housekeeping rules. Number one, please don't forget to subscribe to our channel, Rebooting the Brain, on YouTube, on Instagram, and on Facebook. And please don't forget to like our videos, share, comment for sure, and press the bell icon on YouTube, because it helps us to give you notifications and helps us to improve the reach to more and more people. And I want to thank all our viewers, people who have really engaged with us. I meet so many of them in different places when I go, for your love and affection and participation, and helping us spread the message of neuroscience and the larger messages that we want to communicate. So let's go to the guest of the day. Help me introduce you to Air Marshal Dr. Sridhar. Sridhar, welcome to the show.
Thank you, sir. Thank you very much.
So he has held dual roles. Air Marshal is one of the highest, levels that you can achieve in the Indian Air Force, part of the armed forces, and also he is an excellent neurosurgeon. So you've got a neurosurgeon and who's also in the Indian Air Force. So the best of both worlds. So Sridhar, so you have some opening comments to make?
I always start with Hanuman, chanting, praying Hanuman,
Mm-hmm.
because you can't have a better example of a person who does impossible things in his life than Lord Hanuman.
I agree.
So the Karya Siddhi Hanuman mantra.
Mm-hmm.
Thomasman Karya Niryoge Pramanam Harisattamam Hanuman Yatnamasthaya Bhaya Kshaya Karo Bhava. Asadhya Sadaka Swaman Asadhyam Tam Kida Tvam Kim Vada Ramaduta Kripa Sindhu Mat Karyam Sadhyahe Prabhu. This is supposedly have been said by Lord Sita to Sita Mata to Lord Hanuman when she saw him in Lanka. Please, nothing is impossible for
Correct.
you. Do something for me. So I feel that's invoking the blessings of Lord Hanuman will make all our endeavors wonderful. And I chanted along with you because that's been what we've been chanting in our Kendriya Vidyalayas early morning prayer all along. I am a KV product. So
I didn't know this. I came to know this from you today.
So it's a wonderful way to start a day.
Amazing. Thank you for that shloka, because actually you set the context for this today's talk. Today's talk is going to be talking about the Hanuman of modern neurosurgery, the man who made the impossible possible, who made the traumatic brain surgeries a skill and precision work. And it's a part of the World Neurosurgeons Day. It's April 8th of we celebrate every year. And the man whose birthday we celebrate is called Dr. Harvey Cushing. We're going to talk more about him. He's like, I think, very well fits into the, absolutely. And as you're telling me, I could see, it's a larger than life image that we have. He's been, more than a century, but still, it's so clear in our minds. So coming to the two videos that you saw as this episode started. And the one is from the James Bond movie, The Spy Who Loved Me. And, I think I'm quite sure you also was quite a James Bond fan, when we were young, going to that movies all the time. And that guy used to be frightening with those metal teeth and everything else, that face that looked very different. And that whole, the guy is like a giant coming in and picking up people like this. On the other side, you saw Kali, the Indian version of the James Bond guy, Jaws guy. He's also doing all these things, the WWF guy. So, leaving their achievements and everything else, both of them had a medical condition which is connected to the brain. What was that?
It's acromegaly. It's a misrepresentation. Even though they look gigantic and, should I say, fearsome,
Mm-hmm.
you need to really, whenever I see such people, you feel empathy for them and
I agree.
feel bad for them.
I agree.
Because it's not exactly what is depicted on the screen. They're not strong. They have a lot of problems with their lives, starting with cardiovascular problems to GIT to vision and everything. So actually, you need a lot of empathy. You need to sympathize with them rather than get scared of them.
So actually, I went and did a little bit of homework behind that guy, Jaws guy. And I think he delayed his surgery because he was making money on the movies. And can you imagine he was making money off a medical condition, right or wrong, good or bad, guys? Both of them have a condition called acromegaly. Acromegaly. So, Dr. Sridhar, tell us, what is acromegaly?
Condition where the pituitary, there's a small tumor in the pituitary. Invariably, most of them are small because they start manifesting. The functional pituitary is manifest early.
Mm-hmm.
So it secretes excess of growth hormone.
Growth hormone.
So that actually, since we have stopped growing at the skeletal maturities by 18 years, so anything beyond that affects all other organs. The soft tissues thicken, the fingers thicken, the lips thicken, the facial
The jaw.
jaw starts protruding out. The skin becomes coarse. They have cardiovascular problems because it affects the heart. So these are all effects which actually manifest later on. And the tumor is bigger, then it tends to press on the optic nerves, the vision nerve. But I don't think these tumors are detected much earlier, because the relatives are the ones who start noticing a change in the facial features of the individuals. Their effort tolerance is poor, and untreated, they die of cardiac complications.
Correct.
Most of the time.
Very true. And the ring sizes change,
Ring
and
sizes
the
change.
shoe sizes change. So everything starts becoming bigger. So what Sir is trying to say is, if the growth hormone excess happens before you reach your skeletal maturity, that is under the age of 18 years, you become a giant. And if it happens after that, because you can't grow vertically, the other parts, the peripheries of the body start becoming bigger. That is the hands, the feet, and the face. And that's why we call acromegaly. And that's what is it all about. And did you know, guys, that this is coming from a tumor inside your brain? And you must be wondering, how is that possible? So he mentioned a very important word called the pituitary gland. So, Marshal ji, what is the pituitary gland?
It is the master gland of the body. I mean, it controls all our functions. You look at it, it controls our metabolism. It starts off with controlling our growth, then controls our metabolism through our thyroid hormones. Then it controls our reproductive health, both in males and females. And after you get pregnant, it controls the delivery process,
Correct.
oxytocin. And then later on, it controls the feeding to the baby. And it controls our fluid balance, fluid electrolyte balance. So it's one
stop shop, looks like.
Stop shop for everything.
Amazing, no?
Amazing.
And it's itna maybe a peanut size?
Pea size, absolutely.
Pea size.
So it's something which, and it's so well protected by bone all around.
Correct.
So it's a very fascinating organ, part of the brain to actually understand and read. And when I was reading, actually, when I read, he said when they took the cross section of the pituitary and examined under a light microscope, it looked like a Ganesha, apparently.
Really?
So apparently,
oh my God, I didn't
when
know
you look
this.
at the anterior pituitary, posterior pituitary,
Actually, having said so, that's true.
and neurohypophysis, that part.
Correct. I understood. Yeah. Somebody has actually commented on that. Really? My.
It's there on the net. You can check.
Oh, very interesting. Oh, so such a small piece. So I remember in my first year anatomy, when we are looking at the inside of the skull and, the sella turcica, the small, like a saddle. It's like a saddle. We call it sella turcica, like a horse's saddle.
Turkish saddle.
Turkish. And this fellow is sitting inside that, how God has created a safe space for it to sit. I was fascinated at how, the economy of scale, everything has been packed up so nicely and in such a beautiful place. So pituitary. So what does the pituitary gland do? What are the parts? What does it do? Can you just give our viewers a view on that?
It was actually named by Vesalius way back in 1600s.
Correct.
You meant it actually something which secretes the mucus in the throat.
Really?
That was his thought, actually.
Oh, I didn't know this.
It is not that. So it's got two parts. It actually develops from two different sources. One is its Rathke's cleft. It grows up from the mucosa, or part which gives us a oral mucosa and the structures. And the second part which comes down from the brain.
Correct. One is going from here, one is coming from there.
Both join up. The one that the tract from the lower part disappears. So the only one, it gets controlled by the hypothalamus, which actually comes down and controls it.
Correct. Hypothalamus is the big boss.
He's a big boss. He is a different level. So these two are very closely intertwined. They have a common blood supply. Even though it is, what should I say, size is very small, the hormones that it produces and the extent to which these hormones control various bodily functions are so important that its blood supply is phenomenal. I mean, it's one of the very richly supplied organs, parts of the brain.
Correct. Very true.
Since it needs to sense the various structures, this is another place where the blood-brain barrier is also not it's little given a leeway, like in
Correct.
like we say in service, तो इसको छूट दे दिया for blood-brain barrier. So there are, I mean, it's a very, very interesting and important organ.
Absolutely.
And like you started off saying, it was Harvey Cushing.
Correct.
He is the person who actually started doing transcranial and then did transcranial.
True. So he's saying that one part of the pituitary gland we call the anterior pituitary grows from the bottom and then gets detached from there. The one extension from the top, this is called the posterior hypophysis or pituitary for normal people, and then that's how the whole thing becomes the gland. And this is connected by one boss on top. So what is the pituitary hypothalamic axis? Can you tell us what this axis is? We are all hearing with the Iran war about the evil axis and all that, but what is this axis all about?
There's a nice straight of hormones also there.
Oh, really?
So the infundibulum is a straight of hormones for in the brain. The hypothalamus is the big boss. He controls this pituitary with various hormones and signals. And hypothalamus actually is the part which controls the satiety, thirst, and so many other functions indirectly through the controlling the pituitary. It's very, very important that we need to understand that these hypothalamus and pituitary together are the ones which are driving our body and driving the engine which runs our body. Stress is also controlled by
Even sleep.
So in the internal, the body temperature, when our fever is basically a raised thermostat. The thermostat is there in the hypothalamus. So these are very, and this is actually controlling the entire body.
Absolutely. And not the body to function and thrive and exist and, not break down. So, sir, he said some key words. First, he said satiety is what we say. That is your feeling of not hungry or feeling that you have eaten enough. How many of you have seen you're so hungry? And, and somehow you miss your meal for some reason, because you're busy at work. You get a cup of coffee or you eat a biscuit. And 2 hours down the line, you look at the clock, it's 4 o'clock and you missed your lunch. Has it happened to you? Of course, it would have happened to all of us. Is your stomach full? No. But did you feel hungry? No. Why? Because you ate something, the blood sugar level went up, that fellow hit the hypothalamus. Hypothalamus said, chalo, your sugar is up, you have eaten enough, stop feeling hungry. So you're cheating the brain. Correct? That's what happens. So if you put glucose on your tongue, the same thing happens. So feeling of satiety or eaten enough has nothing to do with food in your stomach, it has to do with your blood glucose levels. Check this out for trivia. Second thing he said is about temperature. Temperature means the internal thermostat. All of us have a thermostat. So sir is saying that, you have the internal thermostat and we are warm-blooded animals. We are not like the cold-blooded animals where the outside temperature determines our body temperature. That's what is happening. So the third thing you said is about the, the fear, the stress
response.
So can you give an example, you coming from the armed forces? How does the pituitary help you with the armed forces?
Yeah. So the ones, your everything. The sympathetic and parasympathetic
Nervous system
is controlled by the pituitary, hypothalamic pituitary axis.
Absolutely.
So that fear and flight response, even though it is perceived in the amygdala, it is controlled here. So your increased secretion of adrenaline, then your response to preparation for stress. So these are all, and to a great extent, these can be conditioned. So that's what armed forces does.
Well said.
That's the way we move ahead. They say the more you sweat in peace, the less you bleed in war.
Really? Repeat that again.
The more you sweat in peace, the less you bleed in war.
Wow.
So that applies to all facets of life. The more you practice every day, the less you will make mistakes during a critical period. That's all it means.
This, I think, irrespective of what we're going to speak the rest of the podcast, this is, I think, the key message that you have given our audience. I'm telling you, it's invaluable what you have said. You have said it so, nonchalantly, so casually, but you do not know the weight. If every of you listen to what Air Marshal Saab has said and follow that, I'm telling you guys, it's going to be incredible. I will vouch for that for two reasons. One is we saw the movie Uri. How's the Josh? Hi, sir. You saw that. Hi, sir. How's the Josh? That's what he's saying about. It's coming from the brain, guys. It's coming from it's all inside the brain and nothing in the rest of the body. Second thing, I had the honor of visiting our brother-in-law who's posted in Rajouri, and we went we were in the camps. From the bottommost guy, everybody said, Jain, sir. And that Jain, sir, is not just for the heck of it. It is coming with that punch, that passion, that nationalism. Sridhar, I think if all the Indians say Jain, sir, I think we'll be a great nation. What do you think about that?
Absolutely. And it is pan religion. Everybody in armed forces says that.
Absolutely.
Basically, it boosts gives you a good feeling because
it gave me morning that Jain sir, the tone that you can't explain it. I'm trying my best to get the right word. I'm not getting the right word. It is amazing. So pituitary hypothalamic axis. Can you imagine where we start with Jain sir, pituitary hypothalamic axis? It's incredible how this so intertwined, this whole process. So we spoke about the pituitary gland. So tell us about certain other. See, I'll tell you one story of mine. There was this young lady who was not getting pregnant, and she was having irregular periods. And then everybody was thinking she was PCOS and being investigated for that. That's a common thing that happens. Some hormone fluctuations, everything else. And then finally, she also didn't realize she started having abnormal milk secretion from her breast. And she was not pregnant, obviously, and obviously she hadn't delivered.
Yeah.
She had actually not been given cognizance to that. She didn't realize for some time, and finally she said there's something not okay. And she went and told the gynecologist, and that's when they woke up, and then they sent to endocrinologist, and then eventually they came to us. She had a pituitary gland tumor. So what is a irregular period and a breast secretion, milk in a lactating woman? And the pituitary gland. How is that connected?
Prolactinomas.
Prolactinoma.
That's another organ, the hormone which is secreted by the pituitary.
Pituitary gland. So that's another. So we spoke about acromegaly, which is the growth hormone. Now you're saying prolactinoma. And then you mentioned about the Cushing, Dr. Harvey Cushing. What is the Cushing syndrome? Please tell us about that.
It was, I think, way back in 2003 or 4 when I was in Lucknow. One young lady walked up into my OPD. Very coarse features, obese, and huffing and puffing. She had very poor tolerance. So the moment I saw her, she had the typical features of Cushing's. So I asked her, round face and florid face, stooped down. So I said, the moment I saw her, I knew what was wrong with her. So I asked her, do you have a photograph of your marriage? She says, you're the first one to ask me. I said, yeah, please show me the photograph of your marriage. Her husband had it in her wallet. She was such a beautiful girl, slim and nice. So I said, don't worry. This is because of a small microadenoma. This tumor is very small, but because it is producing one part of the hormone in excess, out of control of the hypothalamus.
It causes disasters.
It causes disaster. To cut the long story short, I operated on her. She, first 4 days, she took out 23 liters of urine.
What?
So, that is all fluid accumulated in her body.
Absolutely.
6 months later, she was as beautiful as what she was.
Wow.
So that changes her life. So that removal of that microadenoma, functional microadenoma, while preserving the rest of the pituitary, is something which gives you immense satisfaction.
I agree. Guys, what Dr. Saab is saying is not a movie story. It's not a reel, or it's not coming from virtual reality. This is real reality that he's talking about. She must have been grateful to you.
She's very grateful. Even now, she's in touch with me.
Amazing. Imagine such a simple thing. Looks simple when you finish it off. Obviously, the surgery is very challenging. He loves to do those surgeries. We're going to talk about that in some time. So this is called Cushing syndrome. Why is it called Cushing syndrome?
In honor of the man who first described it,
Mm-hmm.
Harvey Cushing.
Harvey Cushing, Dr. Harvey
What a
Cushing.
man. What a man. He was a pathologist.
Oh,
He was a surgeon. He's a writer. He's won the Pulitzer Prize
I knew he was right. I didn't know he won the Pulitzer Prize.
for a 3-part volume biography of Sir William Osler.
Oh, he got a Pulitzer Prize for that. I knew he's written the biography. I didn't know he got the Pulitzer for that.
Every neurosurgeon, actually, when he got into neurosurgery, and in Neman, we were told, you read about Dandy, Cushing, Penfield, Wilbur Penfield. I mean, you need to read about it. In fact, in our rounds, they used to ask, who was he? Who was he? So I still remember my teachers asking. So that always, piqued your curiosity. Went back
Correct.
and read.
Correct.
And I can never forget what reading about him. He's an inspiration.
I agree.
He's trained at William Halstead. Since I was a general surgeon, so that was a nice, interesting part for me. He got an award for demonstrating that hernia could be done under local anesthesia.
Who, William Halstead, huh?
Cushing.
Oh, Cushing. Oh,
Okay.
that's right. I was reading about that. Yeah.
He started off doing the pituitary surgery through transsphenoidal. He was not happy because obviously those days you didn't have light, but he demonstrated that access is possible. And later on he said, please switch to the transcranial route and operate. And he started the first neurosurgery registry. He was not happy with the details of the patients being lost. So documents, the pathology, everything he started maintaining.
Amazing. No, at that time, how meticulous he was. I think he is the first guy who moved from God to data-driven science. It's like that. Sometimes leave it to God. You can't do that. I mean, I'm not saying that God doesn't exist. Obviously, he's there. There is a power beyond us. But eventually, we have to do our work. It has to be data-driven. There has to be evidence-based science at the end of the day.
And when they started this department of neurology surgery, as they called it, he was the first head. He was made in charge of it.
Correct.
What a man. And his greatest contribution, I was really surprised to learn another greatest contribution to the entire medical science is making the measurement of blood pressure popular.
Correct. He brought it from Europe to America.
Italy.
From Italy.
Neurosurgery.
Correct.
So he brought it and made it, and Korotkov added later on the diastolic sounds, but Cushing was the first one who brought it and made it
non-invasive measurement of blood pressure.
He's done so much. And and it's so apt for me to talk of him because he joined US Army in World War I. He's got a Distinguished Service Cross. He got a Gallantry Award mentioned in
My
dispatches.
goodness, I didn't know all these things.
And he joined as a major. And I think when he retired, when he went out as a colonel.
Amazing, no?
And he redefined how surgery is done for traumatic head injuries, shrapnel injuries. He in fact devised a magnet to extract the shrapnel rather than damage it.
At that time, technology was so, non-existent, rudimentary. This was what I think it was running at extra speed. No wonder he's called the father of modern neurosurgery.
He is.
From a messy, bloody, morbid, with high mortality things to bring it to a level of precision. And, I think the morbidity came down by 60-70%, after he sort of defined. And he also got the cautery, the Bowie.
Electrocautery.
Yeah, electrocautery.
Ventricular canal. So many things are named after it. Cushing's reflex.
Cushing reflex. Why don't you tell us, our viewers, about the Cushing's reflex? This is very important, guys, when you have somebody who's had a head injury or a stroke in the ICU. We don't know whether we have to operate, not operate. He's got a clot in the brain, whatever it is, and that's how we measure.
He's the one first observed the bradycardia, the hypertension.
Slowing heart, bradycardia, slowing heart rate.
Slowing heart rate, increase in blood pressure. So, correlated with increased intracranial pressure. He's the first one to do it.
That when CT scan didn't exist, MRI didn't exist. So what sir is trying to say is when the pressure, you have to understand this, anywhere in the body when you get an injury, the body reacts by swelling. Correct? You all know that. More severe the injury, more severe the swelling. Same thing happens to your brain. The more the injury, the more the swelling. The problem, what happens, the skull doesn't expand. The skull doesn't expand. So because of that, what happens is the pressure builds up like a pressure cooker. And that's what he connected, that when the pressure goes up, the heart rate comes down, the blood pressure goes up, and then the respiration slows, and that is the Cushing's triad that you were talking about.
This is the nature's way of ensuring that the brain is perfused. It gets its blood supply. The heart pumps harder.
You're right, actually. Until a time that it snaps because you are not done the right thing at the right time, and then, it's downhill after that at the end of the day. But amazing how much of, cushion, how much of time it gives us to think. But if we don't observe fast enough, then that's when I think the disasters happen more often than happen. That's why neurocritical care is such an important specialty. 24/7 with 365, somebody has to keep their eyes, ears, everything open.
Things can change in moments.
Yes, I have seen. I've turned this way, I've turned that way, the patient is down. It's just dramatic how the ICP can hit you like a bolt from the blue.
And second thing which neurosurgery inculcates in you is to look at the time. It's been a practice that whenever I write or sign, first thing goes to the time, so that I can write the time.
Correct.
Because
Yes,
things are so dynamic in
I agree.
neurosurgery. You need to be really aware of when did you see, and so you can correlate how quickly or rapidly the person did.
Well, and even if it's not you, the next person who comes in knows, oh, sir has seen at this time, this is what it is, and things have changed. So even if the scan was done 4 hours ago, we might repeat CT, which is very easy for us right now compared to what they never had anything like that. So we spoke about a lot of the secretory pituitary adenomas, as what we call the pituitary gland tumors, which secreted a specific hormone like a growth hormone or a prolactin hormone or a steroid hormone, because of which these diseases came up and they manifested. So we also know that some of these pituitary adenomas are non-secretory. They did not secrete any chemicals.
They apparently, now the thinking is they do secrete, but it's not a complete hormone that it can act actually.
Got it. Thank you for that correction. So now, how do those people present? Because can you tell our audience now, because you said they were very small, we got picked up early because there were bodily changes that got picked up. But in a non-secretory or minimally secretory adenoma, how do those patients present?
Now, these tumors are not, they don't announce themselves. Those secretory adenomas are the fancy ones. So they announce themselves wherever they go. So the they actually called non-secretory pituitary adenomas, but the studies have shown that the hormonal sequence that they produce are not effective. These keep growing till they cause problems by pressing on the adjacent structures.
The critical structures around
critical
it.
structures. And the pituitary is located in a wonderful location that the nerves which subserve our vision go above it. Like, as you know, since we have a binocular vision, there's a crisscrossing of fibers. There's a chiasm which is
Optic
called
chiasm.
optic chiasm, and the infundibulum goes through it to the hypothalamus.
Correct.
And optic chiasm forms part of the hypothalamus posteriorly also. So that area, if it enlarges to an extent where it starts pressing on it, then you start having problems in your vision. And it is so subtle that you don't recognize it.
What do you mean by that? Subtle? Why?
It's something which develops gradually.
Okay.
What human beings are tuned to notice are sudden changes. Like today you can move all your limbs. One morning you get up and you have weakness of your limb, you can immediately make out with pain. But this one comes without any pain and it gradually develops. So you body adapts and you stop using that particular part of your vision. So in fact, a lot of people are surprised when you tell them you have vision problems.
I agree. I can tell you. So can you give a story to explain to what kind of a vision problem these pituitaries have?
This happened with a young fellow, serving soldier. He's a driver by occupation. So when he came, when I started talking to him, he reported with headache, and then the neurologist somebody else did a scan and they found a pituitary adenoma. He came to me. This is where I feel sitting with the patient and talking to him, And understanding his problems is a first step. And this is where we always falter. I mean, I think any doctor for that matter should spend a little time talking to the patient.
I agree.
What do you do? What is your job? Like people come to me, I said, what do you do? We had one fellow, he says, I'm in the cyber crime department of Karnataka. I said, that doesn't tell me anything.
Correct.
What do you do?
Mm.
He looked at me, meaning? So I said, what do you do after you go to your office? He said, sir, I keep sitting in the office in front of the computer. I said, how many hours you sit? He said, 10 hours. He said, do you get up in between? हाँ सर लंच के लिए उठता हूँ. I get up in ಊಟಕ್ಕೆ ಎದ್ದೇಳ್ತೀನಿ sir. I get up in the afternoon. I said, what about him? Toilet. I said, see, that is the main problem. See, then you understand how is he using his body and getting. Similarly, this young man, I asked him, what do you do? He said, my driver. So I asked him, are you comfortable driving? He says, I love driving. I was very good. But off late, I've noticed that I brush my vehicle against a pillar while taking it out. Somebody is overtaking me. I don't see him till he comes in front of me. So I asked him, but you didn't find it odd? He said, initially I thought, but later on when I knocked on a motorcyclist on the right side, fortunately nothing much happened. It was happened inside the campus. That's when, and I had headache. That's when I went and reported.
And from that time, that first time he so-called understood that vision symptom, to the time he had the headache was how long?
5-6 months. So he's been neglecting it. He's been adjusting. So I said, what do you do? He said, I used to turn my head to that side to look.
Correct.
So he's losing his peripheral vision. So he's compensating by looking towards that side and picking up his vision. But and then he said, you're the first one to ask me all these problems. Everybody said, what is your problem? Headache. Anything else? He said, no, I am not able to see things properly. So then they did an MRI and then sent to me. MRI is, I agree, it's a very important part of the investigation. But unless you know what you're looking for in an MRI, you can't do an investigative MRI.
Well said.
Just MRI, just for that.
Or they go to eye doctor. As eye doctor doesn't know about for some reason they don't know about it, they'll simply look at eye and say everything's okay. So I'll tell you one story just to say this eye doctor business. This guy is a Kurgi guy. You know Kurgis, one set of Kurgis eat pork. He had a childhood hockey accident and he had lost vision in one eye. He was surviving with one eye. He lived in Papua New Guinea, near Australia. And Papua New Guinea's medical things are very bad. Even for a dental treatment, they need to come to Chennai. So one day he felt he had some vision problem in the left eye. It is the only eye he had. He said, let me go to India and check it out. So he came to Bangalore because it's his hometown. He went to an eye ophthalmologist and the person did whatever it is. He said, you look okay. And dismissed him and sent him off. So now he is sitting like this with a friend of his and having a drink. And the friend asked him, why did you come to India? As the casual talk. He said like this, I had some vision problem, so I came, or the doctor said everything's okay. I don't know whether he was high or that other guy, whatever it is. He said, see my finger. He kept his finger like this and kept on moving like this in front of this fellow. Suddenly, at one point, he couldn't see his finger. As he moved, he saw his finger. He said, do it again. When he did it again, he saw there was one band in his visual field he couldn't see. And when he did it a couple of times, he was convinced that there was
something wrong with him.
There was a hole in his vision, as what we call. Then he went back, chased it with another ophthalmologist, and then they found a tumor in the pituitary, in that area. I'm not going to say pituitary, in that area. I'll finish the story. Then we decided, see, you have some tumor there, we need to operate, blah, blah, everything done, because it was a little higher up near the optic chiasm. We said, we'll go from the top. See, we went in and opened and everything and seeing, there's no pituitary tumor. Nothing is there. So what's going on? We're seeing under the microscope. Finally we realized that the entire optic chiasm was looking very swollen and bulging. The optic chiasm where the two optic nerves, join together. Then the realization happened, there's something inside the chiasm looks like. We put a small nick on the chiasm. Guess what came out? A cervical cyst. A tapeworm. Can you imagine? You should have seen the group And under microscope, it's like, into 10x, 5x, whatever, it came like the glistening thing. Whoa,
Wow, that's really odd.
How-
Really rare.
rare, very rare. In fact, I presented that paper in a NSI conference as a student. It was stunning. And post-op, his vision is fine. So this confrontation test, as what you're saying, clinical side to do, many people don't do this test. So can you educate our audience about this confrontation test, how easy it is to do? For anybody can do it. You don't even have to be a doctor for that.
You need to be aware.
Correct.
You can do it every day. Like it becomes more important as you age or you develop glaucoma. You need to see, you need to be aware that, like now I'm looking at you, I can make out what is happening on both extremes of my vision.
Correct.
So you need to talk to yourself and tell, I'm looking straight. Let me see how far away can I see.
Without turning the eye.
Without turning the eye or the head.
Correct. Or the head also, right.
Then you can make out this is your range of vision. And if there's any problem in that range of vision, you need to go and get yourself investigated or shown to a doctor. But this is a very interesting thing. I mean, you mentioned about going to one doctor and then coming to another doctor. I feel super specialization training actually changes you. Everything changes you. Your mind stretches. It cannot go back to its original shape. Your knowledge and your impressions change. I still remember my professor telling, in NIMHANS, anybody comes to you operated anywhere else, you will not ask, you will not comment on that gentleman, why somebody has done something like you for it. I wish you had done this. He says, you will not even say these words. If the patient asks, did he do right? You are supposed to tell, I am a doctor, not a judge. I do not know his circumstances. The bottom line is, no doctor wants to harm his patient. He wants to help.
Correct.
So please don't comment that somebody has done wrong or somebody has done this or somebody should have done that. You will only say, this is your status. I can help you from now. This is all I can do. If you're willing, let's talk it over.
Well said. Well said.
I think this is something, this message, all doctors should listen.
Brilliant. Brilliant. I agree. I think all professionals, why only doctor? All professionals. Because like you said, we know the circumstance inside which those things have happened at the end of the day. Yeah, absolutely. When we say, in a land of the blind, the one-eyed man is king. It's like that at the end of the day. What happened to what
and the mind doesn't know what the eye doesn't see what the mind doesn't know.
Correct. Absolutely. And everybody doesn't get exposed to the same set of trainings, to cases. Every driver is not the same. Everybody who has a smartphone doesn't know how to use it the right way, and so on and so on. There's no end to.
That's why the world is so beautiful.
Yes, I agree. So well said. So we are now we are moving from the chemical aspects of the pituitary gland to the physical aspects of compression. So when it starts becoming bigger, and this pituitary adenoma is a brain tumor. We call it a brain tumor. Technically, it's outside the brain, but still a brain tumor because inside the skull. But now it's causing problems not because of the chemicals, but because of its physical. It's pushing here, pushing there, touching this, touching that, and creating the problem. So the vision is one aspect. So you said this driver, you didn't finish his story. So he came and he was having this accident to the right side of it. So why? So you said his peripheral vision on the right side was getting affected because this gland fellow is going up and compressing that eye nerve that is there. So, and then you had a pituitary and you operated him and he got well. We'll talk about the surgery a little later. So now, I had a patient. Two patients actually who came in close succession, both of them in the mid-30s, both of them IT professionals, sitting computer like this. And by the time they came to me, they had this bitemporal hemianopia, Sridhar. It was so bad. Both sides they couldn't see. It was dense. They could only see. I said, guys, what were you doing for so long? I mean, educated people, intelligent people sitting on the car. I said, no, sir, I could see my computer. I said, damn it, life is not just looking like a horse, no. They were literally like this, like a tunnel vision. And luckily, both of them, after we operated, the vision improved. And they're both happy, but it's not, everybody is not lucky, no.
You would have had, I'm sure you must have had patients where they had severe headache, they have the tumor inside the pituitary bleeds, they lose complete vision in
Yes,
one eye.
yes,
I've had
yes. Apoplexy, yeah.
and that actually is an emergency because you need to operate as quickly as
Yes, yes,
possible,
yes.
and their vision recovers. They
Correct.
recover
I
to
agree.
great extent.
So it's just one small gland sitting there can create so much of chaos. So much of chaos, and it's not easy to operate also in that location.
So you develop immense respect for the gland. Huh?
Absolutely.
That part of it.
Immense respect for the gland, and we'll wind up with Dr. Harvey Cushing before we go. So here's this man who redefined neurosurgery, who gave us, he was so evidence based, capturing the clinical records correctly. I think all of us have write good notes. I think why don't you tell your comment about your writing notes? How important that is, because there are a lot of young doctors listening to this. Everybody should know that it's not the Google, but your notes that makes the difference.
Actually, when it comes down to others to understand what you have done or what you're doing and what is your impression, the two aspects are important when you're dealing with the patient. One is communication. When you're talking to somebody, you need to look at them in their eye and talk. You can't look anywhere else and talk.
It sounds very simple, but people don't do that. They look at the phone and talking, they're looking here and talking.
Then that person sitting in front of you believes that you're giving him full attention to what, and he deserves it. He's come to you for help. You're trying to help him. So you need to look at him in the eye and talk. First, the first most important lesson that all of us need to have. Second, you need to come down to his level and talk. Make him understand his problem. Treatment is not a one-way street. It's a two-way thing. It's a partnership. It's a team effort. The patient has an equal stake in it, in the treatment. In fact, his effort is more than ours.
And his belief also.
His
trust and belief.
Trust. And this is how you gain your trust. You need to talk to him in his language. You need to understand, spend time, find out how a particular malady or the problem he's come to him is affecting his life. Because that is what he's interested in, that you relieve him of the distress that he has. Not
Hopefully. We may not be able to do it all the time.
Yeah, but at least you're making a sincere effort. And then after you're finished talking to him, then you need to put down your thoughts on the case sheet or in the paper. And there you need to write down in legible handwriting, lucidly, chronologically, he came to me with these problems. This is what I have examined and found. This is my impression. And this is how the treatment I have discussed with the patient. And this is what we're going to do. And for that, to help, I need these investigations. And this is a treatment till I come to an investigation to relieve him of immediate distress. This is what I'm giving. Unless you divide your entire case sheet and write, you will find such scribbled notes. I'm telling you, a lot of doctors do this. Majority of them do that. But there are some who take shortcuts and write something, or common practice, take rounds in the ward, and then you don't annotate at the end of the round what you have said in the case sheet. Nobody is going to believe you if you say this later on. When everything is going well, nobody's bothered. Let one thing go wrong, then everybody will look back at what you have done with a magnifying glass. And this is where they will they'll find faults. And so if you have to protect yourself, you have to do this. It should be a practice.
I agree. First is to write it so that it benefits the patient care. Because even for me, when the patient comes for me for a follow-up, when I turn back and read my notes, it's so clear, including the said he doesn't listen to his wife. That also I would have written there. Literally to all of those. Last time he didn't take the medicine properly. I read all of that because medicine compliance is one of the important things. Because he doesn't do it properly, then you don't expect, the magic to happen. So he said, how do you know? I said, I've written it there. I show my patients, listen, I've written it all here. So whatever he says, I write it down. And for me also, sometimes it helps me to, discipline him. If he's gone back to bad habits, any of those things would help us to understand, who's liable for his not getting better. It's like that. Very well said. I think, the documentation is so critical in this whole process. And I think Dr. Harvey Cushing has done certain standards for us to do, including the registry.
He's the first one to do it.
Yes, absolutely. And many of our The current generation people don't believe in writing notes, for some reason. I don't know what it is as much as it is. Guys, if one thing, forget AI, forget everything else, you must write your observation. God has given you this, your observation, your thought process, you write it there. Invaluable. You learn yourself. You can go back and read your own notes. Oh, I thought wrong. This is different. I was expecting this. Oh, this showed up, and that's a learning for us at the end. And every day, our patients and the world teaches us new things. So now we spoke about the vision problem, we spoke about the hormone problem, we spoke about the tumor in the pituitary gland, and it needs surgery. So that's where I'm going to ask you. You mentioned that Dr. Harvey Cushing was the first man to do the transphenoidal through the nose surgery. Can you explain in reasonable detail what are these accesses, what happens, and why do you like it so much as your passion?
Yeah, because see, it is that cervical, the Spanish saddle. It's sitting at the base of the brain, and it's actually protruding into the back of the throat,
Okay.
and back of the nose and throat where they join. And it's got a nice. Most of the people at least have a nice air sinus in front of it.
Correct.
The sphenoid sinus.
Sphenoid sinus, that's right.
These are all paranasal sinuses which give our voice the timbre and the quality that it has. Resonance, because of resonance. These are acoustics built in our head.
That's a nice word. That's the first time I'm hearing that. That's a nice word.
That gives your tonality to your voice actually. Cranium, lifting up the brain and identifying the
Opening
tumor.
the skull.
Yeah. But majority of the patients, it becomes a a mental block for them when they say, oh, we're going to open your skull and lift your brain and take out the tumor. Here it is so much more simpler. Unlike everybody, you look at nose, everybody thinks that the nose will be going up. Actually, no, nose goes flat back.
Only the front it looks like that. Yeah.
So when it goes flat back, behind you can see the sphenoid sinus. The front wall of the sinus, which actually is hosting this cervical. So you remove the covering of that, then you have a direct access to the tumor.
Amazing, no? How God has created all this thing.
Beautiful. And now with endoscopy, you can see with light and magnification.
Yes, absolutely. Absolutely. I mean, I always, our first episode of the podcast with Dr. Vikram Hooded, I said, God has designed his human body for surgeons. Correct, no? We may all feel that we do a great job. I'm not saying that we don't do a great job, but the way he has built it for us to access, with the least traumatic stuff, at least stuff, it's amazing. So you go through the nose, a natural path that is there. And then through the natural sinus.
It's got a natural opening. All you need to do is enlarge that opening a little.
Correct.
And there you are right in front of the tumor is in front of you. And it's surrounded, you can see the beautiful internal carotid arteries which supply the brain on both sides of it.
First time when I saw it was frightening. Until you get used to it, you say, first of all, your space is so small. It is so much going on in that space.
So it's a nice, wonderful hand-eye coordination that you get to do. And this is one time where we equal the GI surgeons, where they're looking at the scope and operating here. So we are also looking at the scope and operating here.
That looking at the screen and operating is a skill by itself. I thought it looked damn cool when somebody else is doing it, but it's not easy because you're so used to looking at it to see there. You don't know how your hand is moving. It takes quite a little bit of skill to master that. Don't you think so?
Absolutely. And if you're good at it, robotic surgery is the next step.
I agree. But that brain-eye hand coordination is so critical, and it changes with the way we are viewing it. Direct viewing versus an indirect viewing. It makes such a big difference. And for us, because we learned the microscopic thing first, this, versus the ENT guys who started with this, that's where I think they had a head start in handling the endoscope.
Even now, an ENT, you go to a routine ENT OPD.
Yeah.
At least 15, 20 times he's gone into the nose to see everywhere.
Correct. So he's got so used to the whole anatomy and that magnification and the mess that is there to negotiate that whole thing. So you have enjoyed doing that kind of surgery, and the results, like you said, is gratifying. You can see it very well, and you hit the gland first. When you go from the top, you hit the gland last. You have to go through all the normal stuff. Here you hit, nothing comes in your way and do that. And I agree, if you do well. Now we'll come back to What happens if you cannot remove the tumor completely, and whether there's other treatments available and things like that. We'll go to the in a little later, yeah, in our conversation. There's one more tumor that comes in that area apart from a pituitary adenoma. It's called the craniopharyngioma.
Now
Can
this is
you?
this is a remnant of the outpoaching from the throat, which goes up,
Our friend that you said disappears.
which disappears. It's not disappeared.
Correct.
Small part remains.
Correct.
And since it's what should I say, come from the throat, it only secretes mucus inside. And that deposits a little calcium around it. There are two varieties, which in children and in adults. Children ones are usually cystic. Adult ones are usually solid a little. And they are given papillary and adamantinomatous tumors, or a mixed. I don't know, it's my observation. I at least a majority of the children with craniopharyngiomas, I found them a little intelligent. I can't find any reference to that, but they have been a little bright. Their stature is short, just stunted.
Correct.
And poor fellows, they always have a lot of problems subsequently after surgery. Cognition and vision and so many issues they have.
Hormonal issues, probably.
Hormonal issues. In the tumor, in the gland, it is pressing on the gland and causing problems. Hypothalamus causing problems.
I still remember my first, I was a second year student in neurosurgery, 1990 sometime. And this 5-year-old boy got admitted for surgery for craniopharyngioma. And I was taking the history, to write the thing in the ward. I realized as I took the history between the boy and the mother, he was blind in one eye, completely blind in one eye, and he did not even know that was important. And I felt gutted at that time. I had a child who was just born at that time, and my daughter was born, she was a few months old. I was thinking, poor kid, he thought life works with one eye. Completely blind, Sridhar, nothing. There was no chance of us to do anything. And then he started vomiting. When he started vomiting, and then they realized what's going on. They thought stomach upset, then it didn't look okay. Finally landed up with us, and finally we did a brain scan and a craniopharyngioma. And that boy even now comes to me for a follow-up. He's 35 years, whatever, like you said, stunted. But he went ahead and finished his, degree. He is working right now. Still has his challenges, Omaya reservoir. Sometimes the collection comes, you pull it off. But he's progressed in life. But, can you imagine fully blind in one eye without even realizing, guys? So please remember that it's not disease that comes in old age, middle age. These things in brain can happen at any time. So, and so many different symptoms, One side is hormonal symptoms, other side vision symptoms, other side peripheral vision symptoms. I mean, that's what keeps people like us excited all the time, because every day, you have 15 people sitting in OPD, you have to be really on, because sometimes most of them don't even come with the symptoms that we expect them to tell us.
It's a challenge. That's what makes life interesting and challenging.
Absolutely.
It's not one size fits all. You have to think, how will I help him, get him the maximum back from him. So
Correct.
You need to tailor your treatment, change your treatment for different people, different ways. That's where it makes a difference. You need to understand that.
I agree. So we really covered craniopharyngioma. That's why it's called craniopharyngioma. It's very simply the word is put. So we're not here to give you classes on all of those things, guys. We're just trying to make you understand the different things that we deal. All these are non-cancerous tumors in the skull or the head, which affects quality of life more than life itself. And if treated well enough in the beginning, some of them are literally like done and dusted. I think let's change tracks. So you're from the Indian Air Force. And I've always been fascinated by these flying jets and, all of those things, and this dashboards that you have, and the split-second decision making, and the, when you see these air shows and all of those things happening. And yes, I agree, there's a fighter pilot who does all of those things. And then you have a neurosurgeon like you dealing with the most important organ in the body and the most delicate. I'm quite sure our decision making, everything is like a fighter pilot or whatever it is.
Yes, I'm telling you, it's like almost like flying.
So you are one of the few people who had the benefit of seeing both. Obviously I have not seen this aspect of it. So can you tell, I would like to know, obviously the viewers also, how did being in the Indian Air Force and looking at that aspect, hone your skills as a neurosurgeon and beyond?
First thing that I have no service background. Neither anybody from my family has ever joined service.
So what made you join?
It's just that it was fascination. Like I got selected in Armed Forces Medical College.
But why did you apply? Selection is one thing. What made you even apply? I didn't apply.
I'm interested in becoming an engineer.
Oh, really?
My elder brother is an engineer. He did from REC Trichy that time.
Mm.
All interested in becoming an engineer.
Mm.
My parents said one engineer, one doctor. That used to be the thinking when we were kids. So when I got into FMC, my father was very thrilled. He said, "No more bus, go there."
Oh.
And since I was not interested in applying for any engineering, my friend's father, he was keen that his son join and become a doctor. Ramana Kumar, he's in US. He did from Indian Institute of Science subsequently and he's in US. So his father brought the brilliant tutorials papers. They used to come by post those
Correct.
days.
Yeah, I also took that.
He used to say, "Nahi, if Sridhar comes, then I will read." So I used to go and sit with him.
Mm.
And we used to completely remove the biology section of it and read only the physics and chemistry part of it. Mathematics. When it came to applying for colleges, he said, "I will not apply. I'll apply only if Sridhar also applies." So he told me, "Why don't you apply?" I said, "No, I will not apply." I said, "No point wasting money." So he said, "No, I'll apply for you." So those days, AFMC, the prospectus was 25 rupees. So he paid for my prospectus.
Who father?
My friend's father.
Oh, that's a friend's father. That's what.
Ramana Kumar's father bought prospectus for both of us. 25 rupees. And I filled and we posted it. I came to Bangalore to give my entrance exam, interview, and then I joined FMC. He didn't clear FMC. He's in US, I'm still in India. That's a different story. Very close friend of mine. Unfortunately, after FMC, Jipmer prospectus came out of 6 rupees. And we went and felt so bad that we wasted 19 rupees of yours. You have to spend 25 rupees for the prospectus. And once I got into FMC, our biology teacher was non-existent in our 11th and 12th. So I have never read biology actually, except for the last day before exams. When I joined FMC, I was terrified. Will I find something which I cannot cope up with? And I can tell you it is totally different.
It is a baptism by fire.
It's completely different.
Especially for the classical Indian education of doing wrapper to wrapper, ratifying there. You go there. Half the time you don't know what the hell is going on. You know the word, you are nothing else beyond that. It's amazing.
So that's a very interesting way of how I got. And for initial few days, I thought they're going to say, "Okay, we selected you by mistake. Please go back."
You actually thought that?
Actually thought. I was, and I, till I gave.
Because you believed that you didn't want to be there.
I believed. How the hell did I get into medicine?
Normally, Kanali we have a gade dari tappida magatara. Like that.
Absolutely. But till I gave my first term exam, and then I said,
"Okay,
good.
You can survive."
Now I'm in.
I'm exactly the opposite. I want to be a neurosurgeon from 8th standard, so I chased that damn thing. Though I loved engineering.
But once I got into medicine, I was clear what I'll become, surgeon. And then after surgery, as a general surgeon, I've done the full range. I've done orthopedics, fixed bones, fractures, urology, oncology.
I think in armed forces, especially in the periphery, you will get to do.
You get to do everything.
Yeah.
You are the only person. In Kanpur,
Correct.
I've done fracture femurs, I have done nailing, kunsha nailing of the...
Really?
Everything. Fracture both bone tibia, forearms.
Amazing.
Square nails. We've done everything.
Incredible.
So when... only thing which I had not done was cardiac surgery and neurosurgery.
Neurosurgery.
Cardiac surgery somehow didn't appeal to me. So I took on to neurosurgery. And it's again interesting because you have to unlearn what you have learned in general surgery.
Which I agree. Which I tell everybody who comes to me with the general surgery background.
It's a new challenges in you which
Correct.
keeps,
We have to learn to use the instruments. No putting hand inside or doing any of those things. So, but you didn't still answer my question. What made you choose the armed forces in you? I know by mistake he bought the application. Chalo, you could have still exited in a short period of time, short service commission, whatever.
The
By
beauty
four.
of armed forces, I'll tell you, is right from beginning it inculcates a sense of discipline. Everything is ordered. There is order in your life. You get up, you do this, then you do this, then you do this. You come back, then afterward also you plan for the next day. So there's a routine which gets established. And all human beings love routines. I can tell you, as a human being, we love a particular routine. We want to be set in a particular ways.
And those who don't have that also are set in that high. And it cannot be no nothing. There's a statement, sorry to butt in, if you unconsciously don't develop good habits, you unconsciously develop bad ones. That's what you're saying.
So it inculcates that physical fitness in the morning, that correct way of doing things. And I was very fortunate. I'm very lucky that I joined Air Force because.
Was that a choice or?
Yeah, I could have chosen all the three.
I know.
Then my training officer, we have a training officer, a warden kind of thing in the college, training officer who told me, he interviewed me and then said, you join Air Force. I said, okay, sir. I didn't ask any more questions. I just filled it up and gave it up.
The typical our generation guys.
Later on, I'm very grateful to him.
Did you ask him why he said that?
I know. I never had the option to ask him. But I'm grateful because Air Force, there is a safety culture built in right from beginning. Because flying, it depends on safety culture.
Safety culture. I never thought about this angle.
In an aircraft maintenance, everybody has a say. Even the lowest person working can say this is not right, aircraft should not be flown. So it's a very flat organization. Even though there are hierarchies built in, people are encouraged to speak the mind.
Got it.
It's a wonderful organization. I mean, it's a pleasure to work with. The working atmosphere is amazing in Air Force, I can tell you. It's blessed to be there in Air Force.
You said some couple of very important. It's flat, the dishes is clear black and white. There are no shades of gray in between. It either flies or doesn't fly. It's not that there's no point in saying try and see.
So coming back to flying and neurosurgery, there are two aspects of flying. One is flying in war. Second is flying in routine. Routine flying. Routine flying, you have your briefing before, the charts, the weather, the wind, and then where will you take off, then the aircraft status, then you take off and you land. In neurosurgery, you have your pre-op or surgery. You decide this is what you're going to do. You rehearse the steps. There also you rehearse the steps. When you're sitting in the cockpit, you do your safety checks. You do your safety checks inside the OT. Everything is right. The side is right. I'm going to do this. This is operating. It's going to take such a long time. There also sortie takes such a long time. Everything is
correct,
predetermined.
Check the foot switches, that, bipolar, everything.
Done. And then you start operating. And like in flying, initial takeoff is important. Here in neurosurgery, positioning and the planning of the flap that you do for cranial surgery determines how your surgery takes off.
Tell me that. Oh, I agree with you completely.
That's the most important. So, if I am operating, I want to be in the OT right from beginning, right from the time when the patient is induced. I'll tell you a very interesting incident.
Sure.
One gentleman had a fall from a height somewhere in Kerala, and he had a fracture of his dorsal vertebra, and he had paraplegia.
Paralyzed waist down.
And he had, in addition, limb fractures and others. So he was operated on hospital. They did a decent job, except one screw was not properly placed, probably because of the condition that time of whatever is in the operation theatre. So he was transferred to Bangalore. So I said, I can't make him sit up with this screw not being in place. So I need to readjust it. It's a small, it may look good, big, rather, it's not such a big issue. In fact, it's much more easier to readjust a screw than. So he was in the operation theatre. I was sitting with him. I always like to see from the induction. I found his blood pressure fluctuating up and down. Elderly gentleman, he was probably 56 or so, towards the end of his career. And then I found his, what should I say, heart rate fluctuating. So anesthetist said, patient is ready, you can flip over. I said, no sir, I'd like to wait. We waited. 5 minutes later, BP started dropping.
Ah,
6-7 minutes later, he went into a cardiac arrest.
what? Am I?
So now you tell me,
Oh, the
if I
stress induced. Yeah, if you turn upside down, you're screwed.
so everybody would blame you, saying you are the fellow responsible for his death. So it's very good to be inside the operation theatre when your patient is being induced and see what are the condition in which the anesthetist is.
I agree with you completely. I tell all my elderly patients when I operate, see, the biggest risk is upside down. I can do nothing if something happens. So we have to be 200% sure that the 3-4 hours or 2, depending on the duration of surgery, that I can't have everything open. I can't turn you back. It's impossible. I can't even do a cardiac massage. With all those bolsters and everything else there. Whoa, that I can imagine, how it is. I've had my own, share of all this stuff, including somebody blowing a pneumothorax in a trauma, and I had to pause it to
I remember
stick
all,
in.
I remember all my mistakes. I remember all where I've made mistakes.
Yes, you may be thinking, what is this doctor sitting and talking about? We're all human beings. Everybody makes mistakes. At the end of the day, whether the mistakes cost it too much, not cost it, all of us have to learn. There's no way out of it. So to err is human, is what it is. But the training makes sure that, all this training, the protocols, the checklist, that makes it very, very less compared to you were just going in blindly with no plan. And there are some people who do that even now, so-called educated people, in a lot of different things, including investment, not buying medical insurance to everything else. That's no plan at the end of the day.
They need that Hanuman mantra more than me.
But we say God helps those who help themselves at the end of the day. He's one is not going to come and save you. You have to go diabetes and save yourself at the end of the day.
So flying and neurosurgery is almost similar.
I can see that. When you gave me that comparison, I loved it because I knew there was something, but I didn't know that you had sort of sorted it out so nicely and formatted it. So what are the other leadership skills that you have learned from the Indian Air Force that you can advise us? Because I'll tell you, Marshal sir, I feel that the armed forces is one world, the civilian is another world. Organized, disciplined, on top of their game. Here, chaos. They're same DNA, same people coming from the same society. It's not that this guy is programmed differently. I mean, whatever it is. So, why is this happening? And can we? Because I feel that if you follow this discipline outside, we can achieve Viksit Bharat in 2037 instead of 47.
That is because it percolates from top down.
It's a top-down approach.
The system is in place, and it is a ethos of the culture. I'm not saying just because I joined Air Force like this. Army and Navy are equally good. They're a wonderful organization. I've been to an army station. I've served in army hospitals. I've visited naval stations. Everywhere the emphasis is on first cleanliness, orderliness, and doing things in a set particular
Protocol. That I can see. Everybody's, it goes exactly like this.
You take pride in that. That primarily because right from beginning we are inculcated. You joined this organization. You are representing the organization. It is not MS Sridhar who's talking. He is an Air Force officer, Air Force medical officer who's talking. So that you are representing. So if you're talking to another person, interacting with another person, please remember that that entire reputation of the organization at stake when how you're behaving with the other person. And that's a huge responsibility. So if you're made aware of it, I'm sure things will fall in place. Similarly, we need to understand that it is not one citizen or so and so or Nanjappa who's interacting. he should realize this is, I'm a, it goes from like in our organization we say unit, command, and air force, and then armed forces. So here you need to realize it is Nanjappa from this village. So if he misbehaves with somebody, it's a village name which goes bad.
Or the family name, village
Family
name.
name, village name, the state's name, country's name. So if you have that feeling, I'm representing my state or my district, you will behave well.
Cultural nationalism. I'm using nationalism, in the context of if army is a nation, for example, armed forces. And if you extrapolate that, I think that's the best way of doing it. That thing to really make the difference. I think we need that. India needs this now more than ever before. I think for us, I saw that in Japan when I was there. Oh, that kind of, they're gung ho about that. They use everything Japanese. They're proud of what the Japanese do, and they speak the language. There's their habits. Whoa, I mean, Sridhar, I think I don't think any country. I mean, I can see the extremes of this one, right from the small kid on the street, following the rules and things like that. It is incredible how it goes.
We have that chalta hai attitude. No?
Yes. What else points did you learn from the armed forces?
Unconsciously, you pick up so many. You're looking. I mean, it's like a the what should I? The people you associate with shapes you subsequently. Right from beginning, you see people. Even your seniors are behaving the way you're supposed to behave when you get to that level.
So you also know how to behave as you grow in the organization. I think that's an amazing distinction that I didn't realize was. So it's not a surprise for you that when you get there, because you're already trained to be there. In fact, I told one of my juniors who was asking me for some tips to pass the neurosurgery exam. And I said, Bopana, talk like a neurosurgeon. And he didn't understand. He said, what are you saying? I thought he'll give him tips of read this journal, read that journal, do this, do that. I said, listen, unless you drive like a driver, you won't get a driving license. So the examiner needs to know whether I can trust the patient's brain in your hands. So you can't look like an LL board. You have to be clear that you have a clear plan. You know how to execute so knowing the plan is one. Executing the plan is as equally important. And if something doesn't happen the way you expect to happen, what are you going to do in that space? And how quickly can you think on your feet and make those decisions? I think those are, very important, valuable skills. I think, and in your efforts, it's split second at the end of the day.
It grooms you right from the time you join the organization. And you need to keep your mind open and look at others and imbibe their good parts. Everybody has good parts.
And also what not to do. And that's another way, you can...
enough examples everywhere.
It's everywhere to what not to do. Perfect. Let's change gears now. So, Air Marshal Saab, you told me that Dr. Harvey Cushing worked in the US Army, probably World War I or whatever. There's one more guy you were talking to me about, was also in the aerospace, Air Force. Can you tell me about this guy who both of us love, the law?
See, since we spoke of safety, patient safety,
Correct.
is a big thing.
Correct.
It started with Edward Murphy.
Okay.
Edward A. Murphy was an aerospace safety engineer.
Okay. In the US Air Force.
In the US Air Force. He was frustrated with his technician who had wired a part wrong. And apparently he supposed to have said, if there are two ways of doing things and one of them is wrong, people will do it that way.
I agree.
So his in charge liked it so much. His in charge liked it so much that he used it as a Murphy statement in his briefings and in his addresses. So it was meant as a what should I say, a safety precaution for for zero error syndrome or cutting down errors, and it's gone on to in a different connotation in life. So there are multiple corollaries to Murphy's law. Like nothing is as simple as or easy as it seems. You plan for something, it's going to take longer than what you always plan. And if there are 4 or 5 contingencies which you think can go wrong and you plan for them, a fifth one will club up, will make its way. Yeah. And if there are four things going wrong, the one which causes a maximum damage will always go wrong first. And there's a Murphy's philosophy also.
Oh, really?
He says, smile. Tomorrow is going to be worse.
That's a good one.
And Murphy's constant.
What's that?
A matter is destroyed or undergoes damage proportionate to its value. So the larger the value, the more it will be destroyed.
Not like to drive, you buy a beautiful computer from that side of the desk to this side of the desk and open the box, depreciation has happened. You've done nothing. It's just not in a minute. And it's already depreciated. If you want to sell it back, he'll say you have to go pay me this much.
Absolutely. So that's where it goes. That is, they're all facts of life, which was probably stated by the gentleman.
I loved it because I love Murphy's Law. I have used it so many times. But let me give you my own few things about Murphy's Law for the public. Number one, it says when you're standing in a queue, the other queue moves faster. When you go to that queue, this queue moves faster. And when your queue moves faster, you are in the wrong queue. That's the first thing. The one I use very sincerely is, it says, the longer the doctor's prescription, the lesser he knows what's happening to you. So I have a small writing pad. So if I am so conscious about it, I try my best not to turn it over. Very rarely I turn it over, especially when I write the other department medicine. Otherwise, if I have to write more than 3 or 4 in the worst case scenario, I ask myself the question, is it really required?
I think the patient should also ask. I will give you another example.
Oh, sure.
When I was here in Command Hospital as a commandant, or deputy commandant rather, probably, one elderly gentleman walked in, a veteran, saying, I'm not getting 50% of the medicines. I was shocked. I said, why? I said, please show me a prescription. So he was carrying a book and going to multiple doctors. And the pharmacist, in his wisdom, didn't give 50% of medicines because he was being prescribed laxatives, calcium and multivitamin by all doctors.
Without seeing
what he's already been prescribed. So when the pharmacist said, yeah, this is also a laxative. If I give him multiple laxatives, this will lose motion. He'll have only lose motions. So he didn't give him 50% of the medicines, which he really felt were being duplicated. So it's very important for all patients to understand and ask the doctor, why is this? What is this? Or a doctor's duty to tell every patient, this is for this, this is for this.
I tell that. Once I write, I turn it around, I tell this is. Then he understands that I've given it specifically for this, and then you do this exercise, and then you do something else, and then it'll get better. So that's the next Murphy's Law. And then, the other Murphy's Law I like is, there's in the introduction of the Murphy's Law book, it says, Murphy's Law was not written by Murphy. I said, huh? It was written by one more fellow. His name is also Murphy. It's just like a sad joke. And then next he says, all of us know there's, a pot of gold at the end of the rainbow. So somebody went looking for that pot of gold when he saw the rainbow. And when he reached that end of the rainbow, he says, there was Mr. Murphy standing with a silly smile on his face, saying the pot of gold is at the other end.
Tough luck.
Tough luck. So it is like that. So Murphy's Law, guys, if you haven't read it, there are 4 volumes of it or 5 volumes of it. You must read it. You'll get a good laugh for sure. There's so many I can keep on talking, both of us. Just to say that it's a good laugh, but it happens in real life. So it is good to know something. When you say, I knew this is going to happen, Murphy's Law. Diagnosis, that's all it is. When you knew, I guess this could happen, Murphy's Law. So now let's move from Mr. Murphy to your favorite topic of neurosurgery, which is neck pain, back pain. And neck pain, back pain is ubiquitous. Everybody, I think even God may be having neck pain, back pain for all the things that he's doing. So tell us about neck pain, back pain, and your trust with that for the last 20-25 years.
I think when I passed out from NEMANS, as neurosurgeons, you are only taught about diseases which affects the nervous system. But a patient is much more than that. Invariably, I found that somebody comes to me with backache or neck pain, and you examine him and you find some problems and you get an MRI done. And we've always been taught that if you're asking for an MRI of the neck, cervical spine, you should say, these are the symptoms. In MRI form, we have to fill. Complaint so much, findings E. So we're expecting a C56 PIVD on the right side. Then the radiologist will correlate and say, yes, is it there or not? Because invariably, you do an MRI for anybody, something or other you'll not get a normal MRI. Something has to be
Some
abnormal.
degenerative space.
But you have to correlate it clinically. So the radiologist, it helps the radiologist also to see. Most of the time, there were insignificant findings which didn't contribute to the problems or the pain of the patient or the complaint that he's come to you with. So that got me thinking, and that got me to read about biomechanics and how the back and neck are structured. That we know, but how is the posture affecting these back and neck? And the importance of understanding this with respect to patient's occupation and what he does. Like I told you initially, what he does through the day. It's very important to sit with him and ask him, okay, what does he do? Understand his life. And then next step was to reduce it into a simpler PowerPoint presentation to make the patient understand. Because I firmly believe that any patient who comes into the chamber in OPD, first he wants to listen to, he hears only what he wants to listen.
Correct.
He will not listen to you whatever you want to say. By the time he leaves the room, 80% is evaporated. He remembers only again what he has come to hear. When he goes home, he remembers only what he thought was right, and he forgets the rest of it. So I thought this is not the correct way to approach a patient. So I made a PowerPoint presentation on spine care, which I no copyright. I distribute it freely, and when I give it to the patient, I tell them only condition, I want you to circulate it freely to whoever and everybody. See it with your family, give it to your colleagues. So it's to understand that the posture is the single most important component. We as neurosurgeons are, I find a lot of them now understanding and telling all these activities. But I felt I need to go a little beyond. So that's why I made the PowerPoint presentation. And I sit with the patient and explain to him.
PowerPoint.
I explain to him, like I have a spine model. I explain, suppose you're talking about backache. You need to make, every patient will understand, like these are the bones of the back. There's a disc.
You keep it like this so that people,
Disc is nothing but a jelly with a hard casing. So when the load is onto the disc, the weight is distributed radially. So if everything has a tolerance limit, there are muscles in the front, muscles in the back, the nerves are going through the muscles, and everything is held together with a packing material which we call fascia, ligament, whatever you want. So I said, if the force is being radiated, transmitted radially, the casing takes a load. Casing has a tolerance limit. So you take a table, it has a tolerance limit of, can take 100 kgs. You put 1000 kgs, the table will break. Here, if you load it beyond what it can take, the radial force tears the casing, inner jelly comes out, that's a disc prolapse. Then I ask him, now you tell me the problem is the casing tearing or the loading. So then the patient starts understanding it's a loading. And loading is how you start using your back every day, how you use it day in, day out. So you need to understand this very basic concept. The back is fitted into you. You have to look after your back.
Correct. Well said.
So if you're not looking after your back, you can't expect relief from pain just because the doctor is giving medicines. There are 24 hours in a day. You take care of the back by sleeping, taking the load of it, 6 hours, 7 hours. You do some exercises for half an hour. And for 6.5 hours of rest, or 7 hours of rest and 17 hours of misuse, is there any comparison? There is no comparison at all. You look after your back in 17 hours. Nobody can be perfect. So the exercise and the rest is meant to overcome this.
Well said. Got it.
So this Basic concept has to be understood. Same with the neck. The pulley is in front, pulley is in back. The head weighs 5 kgs. So you move your head forward. The pulley in front shortens and takes the load. But the one in the back and the sides, they elongate and take the load. Because they are in constant contraction. So the ones in front are happy, the ones in the back and sides are unhappy. So you keep this continuously day in, day out for long periods. A muscle which is supposed to relax at one particular time forgets to relax. It locks itself, spasm. So pain, spasm, disc prolapse, they're all effects of misuse of the back.
Got it.
Surgery, exercises, medicines are all treating effects. You have
Not
to address
treating
the
cause.
cause.
Before I come more to the cause and effect, you told me one story of a Haryanvi guy.
Oh, that is very
You
interesting.
must tell our viewers that story. In that exactly the way you told me. In that Haryanvi or whatever.
So this was, I had gone to Delhi as head of neurosurgery in Army Hospital, R&R, 2014. People in the difference, obviously each state is different.
Correct.
I had a
Each state is like one country actually.
Yeah. Haryanvi Tau walk into my OPD. I had given him some medicines for backache a month back. He came, he put the book on my...
Slammed it down.
Slammed it down on my table. He said, "Ke dawa diye? Kaam nahi kare." And nobody spoken to me like this when I was in Bangalore. I said, "Baba, baithiye thoda." So he sat down. Then I realized this is the way they talk. He doesn't mean any disrespect.
Correct.
That's the way.
That's his style. That's his style.
That's his style. So then I said, I need to approach him in a different way. So I asked him, "Darad kisko hai?" He said, "Manne." I said, "Kahan darad?" He said, "Kamar." I said, "Kiske andar fit hai?" Then he hesitated. "Mere andar." I said, "Dekhbhal kaun kare?" Then he hesitated a little longer. "Maine dekhbhal ki hai. Mujhe karna hai." Meaning, I said, "मैं तो दवा दे रहा हूँ, देखभाल तो आपको करना है। मैं दवा से ठीक होना है तो फिर क्या बात है? देखभाल से ठीक होगा। इस्तेमाल तो आप कर रहे हो, सही इस्तेमाल करो, you'll get better. Use it properly." Then he said, "कैसे?" Then I explained to him, don't sit for long periods, keep getting up in between, don't bend forward. That's usual drivel. Then I asked him, आप कहाँ तक पढ़े हो? बोलता 8वीं तक पढ़े। I said, आपका पोता? बोलता वो इंजीनियर है। I said, फिर आपको पोता का नंबर दीजिए। So I sent the PowerPoint presentation to his grandson. I spoke to him and told him, please see the presentation, it will help you, and explain it to your father. Grandfather. 2 months later, that old man brought 2-3 of his other ex-servicemen who was in the village, saying, "ये डॉक्टर पते की बात क्या है? इसकी सुनो." So the patient communication and making them understand is very important.
I agree. And no two patients are the same in the way. I agree.
And you should not take offense to a patient shouting in the OPD. If you've been nice and pleasant and greet anybody with a smile, and he keeps asking you questions, you should patiently explain to him the question, because he's clearing his doubts. So when he leaves the room, he should be satisfied.
So what? Got it. So before we go into the cause, the effect, a fundamental question I want you to tell the audience. Is the spine and spinal cord the same or is it different? Because a lot of people mistake the same. Obviously, I know about it. But can you explain in layman's terms to the public?
Spine and spinal cord are totally different.
Totally different.
Spinal cord is what carries your impulse from the brain or from the periphery to the brain. It's a very important piece of
Cable.
It's all multiple cables which are arranged in our body. And to protect it is where the spine is. Because it's such an important thing that it has to have very good protection. Like, it's, to give a simple corollary, all those PVC pipes you put in your houses, which carries the cables, that is spine. The cables are the spinal cord.
Well said.
Just because a casing is broken doesn't mean the cable will not work. Unless it impinges on the cable and breaks the cable, then it will change. So this is very important to understand that both spine and spinal cord are not different. And second thing which everybody bandies around, you ask him, he proudly says, I have cervical spondylosis. It doesn't make sense.
Exactly.
What I told you about the neck, the same thing applies. The discs are there, very intimately adherent to the bone above and below.
Correct.
So you load it, the disc bulges. When it bulges, the covering of the bone, the periosteum, gets stripped off. Wherever it's stripped off, nature thinks, oh, this area is being stressed. I need to stabilize it. So it puts a little extra bone there to take that load. That's nature's way of trying to help you. That is not a disease.
Exactly. Well said. Thank you for saying that. It's like the wear and tear that's happening, and those are the changes that happen. I still remember one 35-year-old guy came and sat in front of me one day. I said, what is the problem? Sir, cervical spondylosis. You know, you had this moral. I asked him the question again. I said, you are looking like a terminal stage of cancer patient. Talking. He was upset with me. I said, listen. He said, why are you saying that? I said, cervical spondylosis is not a disease. It's a wear and tear. He thought his life was done, dusted. Itna mera life aisa ho gaya, kya karu? And then after I explained to him, examined him, told him, he had such a big smile on his face, like a big board that I have removed. And that's all it is. So people are getting stuck with all these wrong things and, labeling themselves and writing off their lives or quality of life. It is so tragic. So it's absolutely well said. So you gave a distinction between spinal cord. What is this disc? Slipped disc. What is slipped disc? I know you explain. Give another explanation for slipped disc, because everybody knows slipped disc.
Nothing called slip disc. You ask me honestly, then nothing called disc doesn't slip. It is so densely adherent to the bone above and below, it cannot slip. The disc is nothing but a, like I told you, a hard casing with a jelly inside.
Correct. Like a cushion or a shock absorber.
Shock absorber of the
Correct.
spine.
Correct.
So when the loading of the shock absorber exceeds its casing's capacity, the casing tears, the material bulges out. It initially bulges and it tears and comes out. One thing we need to understand is, whatever has come out has lost its nutrition from the bone above and below. So give it time, that will shrink and disappear. Unless it has come out in such quantity that is pressing on the nerve and nerve is getting damaged, you need to operate and relieve the pressure so that irreversible damage to the nerve is prevented. Pain will always be there because the human body is actually, an embryo is a cylinder. The arms and legs get pulled out. So the nerve, every segment is supplied with the same nerve. So anything wrong in that segment is reflected back to the brain as something wrong in that segment, especially in the legs. So along the segment they'll be back, and that what the pain shoots down, that is sciatica.
Correct.
That is also not a disease. What do you have? Sciatica. It's not a disease. Pain shooting down the leg because the brain is recognizing something in that segment is wrong is what is sciatica. It can be the capsule around the facet, the joint which is there. It can be the casing of the disc. It can be the muscles which are supplied by the nerve. So any of them, if there is a damage, there will be pain in that segment.
And it radiates down.
Goes down.
Yeah. And see, the pain is somewhere else, the problem is somewhere else. So a lot of confusion happens. The patient's thinking that kidhar se aa raha hai, where is it going, and things like that.
So, and 90% of the neurosurgeons only concentrate of the spinal cord, the nerves and the neural foramen and disc. What happens to the nerve after that? Nobody is bothered.
What do you mean by that?
The nerves have to go through the muscles.
Correct.
If the muscle is in spasm because of misuse, the nerve will not work the way it's supposed to work, and it will mimic a compression. It's basically what you're trying to look at in an MRI is looking at a compression of a nerve. Same compression can occur when the nerve is traversing through a muscle.
Agreed.
So you need to understand where is the compression.
So let me, for the benefit of viewers, let me reword what you're saying. You're saying patient comes with a set of symptoms. Pain in the back, leg, whatever, this area, that area. Now, based on this, you make a hypothesis. Based on this possible hypothesis, you get a scan done. Now, this scan has to match this, is what you are looking at. Correct me if I'm, that means it's called clinico-radiological correlation. Now, can it not happen? Of course it cannot happen. We see it all the time. So, if it doesn't happen, it doesn't mean it doesn't have a problem. He is having a problem that the scan is not showing. And the scan is not showing because the scan is only showing so much. The problem is in the neighbor's house. Is that the right way? And that is the myofascial component that you are telling me. And that is what most people miss. And I'm telling you, Sridhar, I am a victim of this as a neurosurgeon. Till about 2009-10, I did not understand this concept of myofascial pains in a big way. Until I met a good pain physician called Dr. Raghavendra for the first time. And that's when he started showing me how this pain mimics, the pain mimics a sciatica, mimics a radiculopathy, mimics a root pain. And those trigger points he releases, the pain goes like magic. And you are saying exactly the same thing. And I think that has redefined both our practices, significantly.
So you need to help the patient.
Absolutely.
I had a pain specialist called Group Captain Sunil Chaturvedi, my 4 years senior. He used to inject into the muscles.
Correct.
To relieve the pain. And they have a lot of relief. I thought, why do a invasive procedure? So I tried finding the knots. And that's when my interest in biomechanics and myofascial syndromes improved. And I found that a patient having a pain, the multiple components of it. So you relieve only, even if you relieve 50% of it, patient is very happy. And initially you relieve the knot, the pain goes, initially it's very painful, but subsequently the relief is immediate. And same with the legs. The piriformis, which is deep inside, is the first muscle to go into spasm, irrespective of what happens in the back.
You said a very important thing of this, knots in the muscle. As a neurosurgeon, I understand that, I learned about that called the trigger points. I know, I've done it, I've looked for my patients, I've done all of that, guys. Okay, I've been practicing this for more than 15 years now with very good results. So then I met Dr. Sridhar recently as a part of discussing for the podcast. And here I'm introducing one very interesting concept. You're going to see the demo shortly, called the Sridhar's maneuver. I've called it the Sridhar's maneuver. I'm just telling you, it's for because he's the one who gave it to me. So don't practice it, just watch it, as this video goes ahead. And I'll give you one more thing. If you watch this whole episode, you subscribe to our channel, you put your comment, we will give you a copy of his presentation free, so that you can have it with you. That's the promise, correct? Because we want them to engage and understand what you're talking first before they get the value of it, because they're not consultative. So coming back to this, so we were sitting face to face to talk. And I know sometimes I have this neck stiffness after a long surgery, something. I just do this. It's not hurting me. But sometimes it doesn't feel okay. So I would do that, but it was not bothering me, though I have enough people to release it and all of that. So I was just casually. He said, let me demonstrate to you. And what you're going to see, on the video subsequently is how he demonstrated to me what happened. And he touched me on this side of the neck from the back here. And I actually winced in pain. And I'm telling you, Sridhar, I didn't realize I had a trigger point there. And I am somebody who does this. I'm not saying that, though I was not looking for the trigger point, just release the muscle. I had not experienced. So that was a latent trigger, I realized. It was not an actual trigger. Subsequently, when I said that. And then he asked me to lift my hand like this. I lifted my hand. And he said, straighten it. And I straightened both. And I suddenly realized this hand was weaker. And I myself didn't realize that I'm operating, I'm exercising, I'm doing my push-up. Didn't realize my Surya Namaskar. Didn't realize that. Not paid. That means it was so subtle that even a neurosurgeon who treats with this hadn't picked it up. And then he said, let me show you how to get it better. And that you're going to see this right now, how he's going to. So tell me what you did to me, as I call myself a guinea pig for myself. I know I'm not a guinea pig for you. You've done thousands of this. Tell us how it went.
I've been doing it since 2004 or 5.
2004, 22 years and going strong.
Initially, I used to feel for the trigger points and the knots and press on the knot with full force with my thumb.
Correct. And it's
So
very
direct
painful.
pressure pains miserably to the patient, and my thumb started degenerating. So I stopped doing that. But
And it can damage you as a surgeon,
it gives immediate relief to the patient because the knot just dissolves.
which I've seen.
So and the patient improves. So then
Gun
I realized,
in Kannada we say gun bidsadu.
but then I realized the spasm of the knot is there means the muscle which is supposed to move its full length freely is stuck in a particular length because it's not going to its full length.
Correct, it's not stretching.
So I stretch it to its full length, understanding which are the muscles which are in spasm.
That's what you did to me.
That breaks the spasm. And the catch here is to hold it in the extreme position for at least 10 seconds. And I tell Gayatri Mantra in my mind 3 times, and that is 10 seconds.
When you told me this, you know what I got? I said, not only you're counting 10 seconds with 3 Gayatri mantras, but you're putting the divine energy into this whole thing to give that extra benefit.
So it adds, so and then you release it. Immediate spasm relief is felt there, then and there.
Ask me. I actually didn't realize that I was having a problem only until my, the neck felt better. It's like your vehicle, no? When you give it for servicing, it comes back and moves better. Then you realize my actual vehicle was not okay. But you got so used to it because it's crept on me so slowly, I never even realized that. That's amazing, Sridhar. For me, having practiced neck pain, back pain for at least more than 2 decades, it was an eye-opener for me. Thank you for that maneuver. Plus, don't practice this tomorrow morning, guys. Even if you are a professional, you have to go through a training with Dr. Sridhar for sure. Understand what he's doing. Maybe do initially under his supervision. Only then you can do, or somebody like him.
So as a corollary, if somebody has got weakness, and after the maneuver his weakness improves, then the compression is not obviously not.
Oh, it is here.
It is here, not there inside the spinal cord. So no point getting an MRI done for him.
Correct. Oh, so you're saying that you try this first before you do the MRI. What about the risk that sometimes if it is on this side, it can get worse? Is that possible?
Yeah, you see, the entire structure is built so rigidly and strong. Unless there is a fracture where he cannot move his neck at all, anybody who's got a pain can be subjected to it. But it needs to be done in a very controlled way and in a very deliberately and slow way. And you need to respect each person's age also when you're doing it.
What happened if an elderly person, frail person, or very frail, looks very weak?
The amount of force that I use is very minimal. And more importantly, you need to talk to the patient, explain to him, and he says, please stop. Because you're trying to help him, not to torture him.
Yeah, so they should be very careful. But that was brilliant. I think that was something that was so easy to do. I think many times big problems have simple solutions. I always tell my patients with neck pain, back pain, the symptom is out of proportion to problem. The symptom looks so big, it's like my life is gone, but the problem is so small, and sometimes it just goes away like that. Trigger points, there's so many, sometimes 5-10 trigger points in the neck and the back, and that can be quite distressing. So we'll start from myofascial pain and then work our way backwards to the spine and then the spine surgery, so that we go from the simple to the complex. You also told me, and I subscribe to your model, that I'm also a very conservative spine surgeon.
Surgery should be the last option.
Correct. So I add one more thing to that. I say those surgeries should be the option. In certain cases, it can be the best option if, like you said, there's a deficit and things like that.
Deficit or instability.
Yes.
You need to.
Then we know. So all I'm saying is, when you say last option, it's not that, Gatinella for survival is not there. You have to make sure the right things, conservative treatments are sorted out. 3 to 4 weeks minimum, especially when there's no neurological deficit, before we decide this is medically intractable or whatever it is. Either we are missing the diagnosis or something else is going on. Everybody thinks every disc in the back has to be removed.
And I keep telling, when we operate, we're removing the effects. So you address the cause. Cause is 80% treatment. That is your effort.
What is this cause you're talking about? I want to know this.
Cause is the way you use your back.
What do you mean by that?
It's a biomechanics. You need to understand how you're loading your back.
Okay. Can you explain in English?
I'll explain in English. If you look at, I'll give you a simple example that you go to buy 1 kg of tomatoes. Nowadays you get electronic weighing machine, but olden days you used to have the weighing scale.
Correct.
You'll put 1 kg stone, he'll give you 1 kg tomatoes. Now, that happens because the fulcrum is in the center. You move the fulcrum to one side. So, whichever is a longer arm has to have to lift that longer arm. It is easier. But to lift the shorter arm, you need to put more weight. That's how some of them used to cheat in olden days, that fulcrum may not be in the center, or the weight will not be the exact 1 kg. To cut this long story short, if the longer the fulcrum, to lift the long arm, the short arm has to generate more force. So whenever you're bending down, if you look at a kangaroo, it's got a long tail, so it bends happily, even though it stands on 2 feet and its front paws are small. When we bend, we don't have a tail. So whatever is the back muscles in that area and the structures, the fulcrum is in the lower back. So when you bend down, whatever is your body weight, the trunk is around 2/3 of the body weight. 10 times. The longer the person, more is the load on the lower back. But at least 10 times is held by the lower back. So if you're 60 kgs, 40 kgs is your trunk. When you bend down, 400 kgs are being taken by your lower back.
400?
10 times.
10 times.
So once in a while it will do. But if you do it routinely, and to top it all, you lift another 5 kgs.
Correct.
10 times another 5 kgs, 50 kgs more is added.
And in the wrong position when the spine is opened up also.
So you're misusing your back and you don't want it to be damaged. It's like you're banging your car against a wall and say there should not be a dent. Not possible.
In fact, low back pain is the single biggest cause of loss of man hours in the world today. A simple, stupid problem called low back pain. So I give this as just to tell Dr. Saab what I say. I say, including us, we can have back pain because we are also human beings first. But if we don't take care of our back, imagine guys, I'm operating. Halfway through my surgery, I get back pain. Imagine me say, I can't operate, I close it and told my patient, I've done half surgery, come back next month, I'll do other half surgery. Will you accept? Of course not. Can I operate with back hurting me? No. So guys, remember, some of you can go and come back later for other half, say I want to take leave. We cannot do that because we are in high performance situation at the end of the day. So what's your take on this kind of stuff?
That you need to understand. You need this again. We are bound by habit. You look at any activity. Most of the time, we are doing things out of habit. We want to finish particular thing and then go off. There's nothing called finishing a thing. What is definitely there is doing it better, doing it well. Nothing called finishing. So you're operating continuously, somebody in front of the computer for long periods, or somebody is holding a meeting for a long time. They come to me with backache. I said, you're the chairperson of the meeting. He said, yes. He said, please get up after 1 hour. Looking at you, everybody will get up and they will also be benefited. Take breaks. Nobody's told you to sit continuously for 1 hour. No logical order is given that you will sit continuously for 8 hours. Nobody says that. It's your habit. And people say, no, habits are very difficult to break. I said, no, they're the easiest to break. You do a particular activity consistently for 3 weeks. After that, it is automatically a habit. So that is where armed forces teach you. You do a particular thing consistently. Initially, you will crib. You will complain. But after 3 weeks, it's part of your routine.
Correct. Even sometimes without you even realizing
it, you're doing it. So it's very easy to change habits. It's not very difficult to change habits. But you need to make conscious efforts in the first 3-4 weeks and then it's done.
Consciously be aware of what you're doing. So coming back to, you mentioned something called the piriformis syndrome or piriformis. What is this piriformis fellow?
There's a muscle deep inside.
In the bum?
In the bum. It is attached to the femur and to the sciatic. Sacrum. It is bridging the sciatic notch. The sciatic notch is a notch through which the main nerve which supplies the leg goes down.
Correct.
The
sciatic nerve.
Sciatic nerve. Now in 15%, 10 to 15% individuals, the sciatic nerve goes through the muscle. In rest of them, it goes under the muscle. It's a very narrow space. If that muscle is in spasm, and that's the first fellow to go into spasm when anything goes wrong in the back. Posture is back because that fellow goes in spasm. That will mimic a disc prolapse in the lower back always. And it may be part of the disc prolapse also. I've had patients who come to me with pain. I relieve them of the piriformis spasm. Their weakness still persists, or weakness is out of proportion to the pain. Then I get an MRI done and it's shown a disc prolapse, and we've operated and relieved them of their
And it
problem.
also justifies surgery. So piriformis can also happen if you carry a wallet on the back pocket.
If you sit awkwardly, sit for long periods. Wallet is if you actually say I'm having a wallet, when you're sitting, the wallet goes to a side actually. I'm not sitting on my wallet.
But if you sit on or pressure on that point, then that's
Because
the common.
it's tilting your seating.
That also can have an impact on your biomechanics of your
Everything boils down to
biomechanics. So, can you explain the word biomechanics in English for people to understand? It sounds like a very sexy, sophisticated word. So, in English means what? Biomechanics.
It's a forces which are which a biological tissue is subjected to because of the various actions or structural forces which are impelled on the muscles or the biological tissues by the posture in which that particular part is being kept.
So, now you tell me, if I bend like this, there's one biomechanics. If I bend like this, there's one biomechanics. If I do this, there's something else. If I do this and bend forward, something different is happening. Correct? No. If I do this and reach back, something else.
So different structures are being stressed out in various activities. So what happens invariably is
sometimes you go back and do this, you get a catch at the back. Yeah.
Because that part which is not accustomed to doing that particular activity has suddenly been made to do. You don't climb. So I'm not a mountaineer, but suppose suddenly we told you run up Nandi Hills and come down, for next 1 week you'll not be able to walk properly. Because those muscles which have never exercised are made to exercise, they are in spasm. So that's a activity over a period of time. But imagine you bend down suddenly and lift a huge weight. Back is not accustomed to lifting a weight, and then it goes, so that particular part locks, or the ligamentum or the annulus tears, and you have a disc prolapse. It's all understanding how we are stressing a particular part of the body.
And each of these so-called, you said the tissue, the casing and all of those things you were telling us, each of them has different tensile strengths and properties which also
have to
take into account. Now, I'm going to introduce another word which you had told me. One is the biomechanics, second is the ergonomics. How do these two work together? Is there an interplay with the two?
Ergonomics is a way of optimizing your workspace. Whatever work you do. I'll give a simple example. Like there's a way of choosing your chair. There's a seat pan depth. Height.
Like your chapel. You go and put your foot first there. He takes the measurement and does.
So it's basically making yourself feel comfortable. Like when I sat first in the session, I said I don't want a pillow for my back. But then I realized I need a pillow because my thigh length was, I'm not a very tall person. I'm a short person. So my thighs were actually falling short of the edge of the sofa. The knees have to be at the edge of the sofa. So I asked for a small pillow and I got it. Now I'm comfortable. So it is up to you to understand, and it's not very difficult. You need to be aware of your body. So, and that is my entire endeavor. I keep telling, and whoever I've given my presentation to or explained to them, 90% of them not come back. Very few come back.
No, that's an amazing presentation. Amazing presentation.
So they understand. They understand where they're going wrong, and they correct themselves when they go on.
I loved it because with those pictures you put, you explained it so well, and people realize what happens to a disc when it degenerates. Everything you are given there so beautifully. You must, all of you, have a copy of that for sure. And at the end of this episode, and then we'll see what happens. Very nice. So you also do. So coming to biomechanics, the chair you said you had this thing. I'll give you my own one example that I had. So just before COVID, first lockdown, we built a balcony in our house, and I bought a cane chair and table, and beautiful cane chair, and within 1 week of that coming, the first lockdown is announced, And we were not frontline. The first wave, so there was no cases also. We were just sitting at home twiddling our thumbs. So I started working long on laptop, doing some research work, reading work, right, whatever. After about 3-4 weeks, and then I started walking more because, we were unemployed. I had more time to do it, more exercise, more walking, 20,000, 30,000 steps a day. Then what happened was one day I started developing pain in the right trochanter, in the hip area on this side. I could walk 30,000 steps, but I couldn't cross my leg like this to tie my shoelace. Excruciating pain. I had to keep on doing this. I couldn't figure it out after some time. I went to my orthopedic surgeon. And he said, you have trochanter bursitis. I said, what the hell is that? Then he tells me that when you sit on the chair, your hip has to always be higher than your knee. And my chair was like this. And in that chair, I was bending forwards because I was working on the laptop. He said, Sharan, that's the worst thing to do. Imagine somebody like me didn't realize that. The moment I changed my chair, this pain disappeared. But for that pain, I had to do laser treatment. So I'm getting it clearly that simple as wearing the wrong size of anything, footwear or anything else, like how the chappal bites you. This is what Sir is saying very clearly about not doing it properly. Now you also, like the Sridhar's maneuver for the neck, you have one for the back for piriformis. So, the demonstration is going to come shortly, but can you tell us what you do and why is that important?
Same, the muscle, piriformis muscle is, you need to stretch it to its full length. It's in spasm.
Got
The
it.
same principle that is there in the neck.
The neck, what you demonstrate just.
Only thing, this is so deep inside, then you need to use a consistent force, at least same, 10 seconds to 15 seconds. And it has to be a consistent force. You use your arm, what happens is invariably your arm tires. These are not meant for consistent force, unless you're a bodybuilder or a, So I realized, again, I'm a short person.
Correct.
So the same maneuver, I have an exercise chart which I give to everybody. But in that maneuver, I take it to the extreme by putting my entire body weight on that. It looks very odd to somebody watching it. But what I then again realized, only if I do it, it's not making and that's a very simple, anybody can do it. So if the husband has come with the wife, I do once from the wife, and I tell the husband to do it twice, so that he knows how to do it and he can, in case required, do it at home, or tell his wife how to do it for him if it's required. So you're educating your family. So I invariably tell them how to do it.
Nobody has come back with an injury, doing it wrongly and things.
No.
So it is not.
Once in a while, somebody's had some pain in the chest because of extreme. Otherwise, no, that also disappears.
Perfect. So let's now move to the low back surgery. Let us assume that the patient has not benefited from anything that you've done. It's not myofascial. It's in the spine. You found, an offending agent there. You tried your medical line of treatment. It hasn't worked. Rest, medicines, physio, nothing has worked. And you think that his problem or the neurological deficit is there. Then what is the benefit of surgery? Because enough people, even today, people say, never get a back surgery done. People are psyched up about back surgeries and things like that. So what is your advice what is your reassurance to the patients and families, and what is your advice about surgery itself?
When they talk of surgery, they want only minimally invasive surgery. Everything has a particular role to play.
Correct.
You'll have exponents who will say push minimally invasive for everything.
Like a vaccination program.
But then you need to understand, you're treating a patient. Every patient is not an Everest. If you have a hammer in your hand, everything will look like a nail.
That's the problem that's happening.
You need to tailor the patient's condition or his findings to the best option that he can have.
Surgical treatment wise.
The whole aim of surgery is, you do it once, he should not be able to come to you with the same problem again.
Well said.
So you have to do it well. For simple, small, single discs, an endoscopic procedure is excellent. I've done that. But you need to understand, endoscopic procedure say there is no tissue dissection. There is all. If you are interfering with the tissue to go inside, there is always tissue dissection. So you can do the same with the micro lumbar disc.
Correct. Which is what I do. I don't do endoscopy.
I've done endoscopic. I've stopped doing it. I do only microscopic now. Then some of them they do minimally invasive spinal fusions. That is very good for fixing the spine. Instability. But instability is only one component of the problem. There'll be compression, there'll be root compression, there'll be a flavum hypertrophy, facetal hypertrophy. Unless you relieve that, this is not going to. So you have to. So at that level, at least you have to combine it with an open procedure to remove all these compressions.
Absolutely.
So you need to do a hybrid procedure.
Hybrid procedure. I do open, but I know, like you said, you have to chase every root, every symptom, everything. You have to clinical, radiological, keep going and looking at the scan. Make sure everything has released well. Only then you have gratifying. I've got some fantastic results. People have gone back to playing sports. I've had people who couldn't walk 10 meters have gone back to US for a visit.
My soldiers have gone back to fighting.
Really?
Shape 1.
Amazing.
Which is a full category. So you need, all I'm saying is you need to determine and decide. I had this gentleman you would have heard of, Mr. Abhilash Tomi.
Yes. You tell us the story. I forgot about that.
Very interesting. He's
an armed forces guy?
He's an armed forces guy. He's a naval commander. He had a fall while doing the circumnavigating race.
What is going around the globe, no?
Around the globe
in a small
sailing boat. In a
sailing boat?
Yes.
Alone?
Alone.
That must be.
He had a fall and in a storm, and he had a fracture of his 2 dorsal vertebrae high up.
Where was this? In which part of the world?
Pacific Ocean.
Pacific. Oh, that was the worst ocean.
For 2 days,
Huh.
he had nobody to help him.
My goodness.
He managed.
Mm.
Then he was picked up.
Where? How did he? He could communicate.
He managed to communicate.
Mm.
He was picked up, brought to Visakhapatnam. Then he was brought to Army Hospital, RNR in Delhi. I operated him the day he came. I fixed around 8 screws in his back. Made him walk. He went back to being a sailor. He took retirement from services. And then he completed the race the second.
My goodness, crazy chap.
And he came second.
What? Amazing.
Look at his fortitude. All I did was fix his spine. I'm telling you honestly, I didn't done. It's his commitment, his courage, and his determination to do something that I have to do it. You can learn so many things from him. He's a wonderful human being. I'm telling you.
No, but what you're saying is what Sir is saying is, grade 1 fitness means fighting. You can go back to fighting. That means back surgery is not a survival surgery. It is not just to walk to your work or walk to your bathroom. You can get back to an absolutely fit condition. Even both are, cricketers, Hardik Pandya, Bumrah, underwent spine surgery and they're back to that level of jumping on the field and bowling and batting and fielding and jumping and falling and everything else. Guys, if done well. So that's why we always recommend, a good, neurospine surgeon is the right guy to do this work. And I think that's very
My professor used to say back surgery is the most difficult surgery. He says to choose the correct patient.
Correct.
And the correct procedure for it and do it well.
Correct. I agree. Sometimes it looks so simple when you do it, but I agree with you completely in those 3 points that you said.
It is not a life-saving surgery. It's a lifestyle-modifying surgery.
Correct. And quality of life surgery. I had one guy, he was a bit mountaineer. About 47, 48, had back pain for a long time, kept neglecting. In between, somebody suggested surgery. He said, I have no time. I was just going. One day, over time, it became so bad, severe back pain, severe neurogenic claudication. He couldn't stand, walk to bathroom. He was disabled. Then came and saw multi-level, compression, both foraminal and canal compression. And also, he had some instability. So he's in bed, okay? He's not able to walk to bathroom. He says, Doc, I have one condition. I said, what? After this surgery, I want to do the base camp of Mount Everest. I just looked at him. I said, boss, you are not able to walk to bathroom. Now let us fix the basic. I will do my best. But whether that best is going to land up going to the base camp of Mount Everest is your effort as much as my thing at the end of the day. You won't believe it, Sridhar. 9, 10 months maybe after the surgery, he did the base camp. And he sent me a picture from there. And I had tears in my eyes because, see, he proved that I'm a good surgeon. At the end of the day, if we do what we do, but when these guys come and show, like how your Abhilash Tony did, then sometimes I'm not doing a bad job at the end of the day.
So it's but hats off to their determination.
I agree. Totally, it's to them. That's what they, over enhance our reputation. Worse than anything else, to give more credit than what is due, probably.
So treatment is a two-way. It's a team effort. It's not a one-way street.
Absolutely, I agree with you. I absolutely agree with you. What is called. So let's move. And so what sir is saying is, we're not going to details of spine surgery. This is not the context of today's talk. But spine surgery, you've done well, timed right, the right things are done. You can more than go back to life and live it at your terms. That's basically what it is. Let's move to the neck. There's something called text neck. What is this text neck that everybody is talking about today?
These are all new terms which have come up.
Correct.
It's on texting. You will find
texts.
People are texting while driving. People are texting while on the cycle, on the sides of a railway track, but doing the daily jobs. I've seen them all. So what happens invariably when you're texting, you bring your neck forward as much as possible. Same principle. So every time like I told you, if the neck is straight, the muscles, both muscles in front, the bones are small. The weight of 5 kgs is taken. That's a load on these structures.
5 kg, you're talking the weight of the head.
Weight of the head. So every time it moves 2 centimeters forward, the load doubles. So 5 becomes.
How many centimeters forward?
2 centimeters.
2 centimeters.
So that means if you're keeping it here, it's full 6 centimeters. Full flexion is 6 centimeters from here normally.
Correct.
So it's 5 becomes 10, becomes 20, becomes 40. The structure is supposed to hold 5 kgs, is holding 40 kgs. So it will go into spasm. So everybody is doing this. So that's the pain which causes is called text neck, because you're texting continuously.
And the stoop posture.
Stoop posture. The correct way, at least if you're alone in your room, I always put it on speakerphone and talk. Simpler. Or you have a stand and then you talk. Or you keep it there and see.
Correct.
And more importantly, don't do any activity continuously. All activities are permitted. Take a break.
Got it. And and the posture, you can correct the posture by doing that and all of those things. Basically, guys, text neck, all of us are going to be prone to that because of the stoop posture, and that can change the biomechanics of your spine at the end of the day. And over time, it may not give you complaints today, but 20 years down the line, 15 years down the line, for sure it will become a mess because it's not aligned properly. We spoke reasonably about neck pain, back pain. I think you have covered a lot of aspects of that. Thank you for the maneuvers that you have demonstrated and how a disastrously sounding or suffering pain can be so easily handled, and we can give reassurance to the people. So I want to ask you another story that you told me about that girl, the child called Savita Dwivedi.
Sarita. She is an inspiration.
So can you tell us the story? What was that all about?
This was a general surgeon.
When you were a general surgeon?
I was in Kanpur. Kanpur from 94 to 97. February 94 to August 97. She came in 95, I think. So she came from Allahabad. She was a small 5-year-old child, 4 or 5-year-old child. She held on to a high tension wire in her roof.
Are you? How? Playing?
She was playing. The wire was low slung. She held it on with both hands. She came with severe electrical burns.
My goodness.
She stayed in the hospital for almost 14-15 months.
What? 15 months?
We looked after her. Very cheerful child.
And what happened to that?
She had finally a 4/4 amputation on both sides.
The hand is cut here? Both sides?
Both sides. Right leg below knee amputation. Left leg, she has a equinus deformity with scarring.
So the right leg cut below?
Cut below knee amputation. She's got a artificial foot for that. She's in a wheelchair. I lost touch with her. She contacted me later on when I was in Deputy Command 2014, 19 or 18.
Oh, 20 years later.
She's a young lady now. Beautiful, wonderful young lady. She paints with her mouth.
Pains with the mouth.
And she's finished her graduation. She works in Alimco in Pune as their advisor.
Mm.
And she takes part in the international Olympic
Paralympics.
and she's
Ooh.
won medals.
Really? My goodness.
So having a handicap is physically is different from handicap mentally. You can overcome any physical handicap with a mental strength. Amazing. And we always complain, "Ki ye theek nahi hai. This is not right." No.
Crib and cry for all useless things. Absolutely. Starting with the traffic for sure.
What a lady. What a lady.
Amazing. I still remember, my mother used to subscribe to Reader Digest when I was in school and college. And one of the statements there had said, which I love and, use it regularly, is I was crying that I had no shoes on my feet until I met a man with no feet. It's exactly what you're saying at the end of the day.
She is a wonderful lady.
Amazing. Painting with her mouth.
And such intricate painting you can't.
Yeah? You had one hell of a journey in your life so far, and you're not done as yet. I think let's go to the the next segment, which is stereotactic radiosurgery. Let's go back to the brain.
Yeah.
So you have said that you have done a lot of stereotactic radiosurgery at R&R in Delhi.
I was posted to Army Hospital R&R in 2014.
Okay.
Only two things I had not done till I had gone to Army Hospital R&R. One was deep brain stimulation, and second was
there's a pacemaker in the brain.
Stereotactic radiosurgery, both which I did in Army Hospital R&R. For stereotactic radiosurgery, we were very fortunate. I was very fortunate that time that two people were there to mentor me or take me through the steps, who had undergone the training in Sweden.
Oh, with the man.
The man.
Professor Lars Lexell.
Yeah. One person was the radiation physicist. He's come from DRDO. Dr. Semwal. Oh, you should look at that gentleman's commitment and his demeanor and the way he carries himself. Amazing. And his knowledge. Superb. Fantastic he was. And second was, now she's a current DGFMS, Aarti Saran. She was also there as a radiation physicist. Both of them used to take me I used to sit with them and understand, read. And it took me around 2 months to be on my own. Now I understood the planning, the execution, and what you do. And very fascinating.
It is fascinating, don't you agree? I think this is the future of neurosurgery. So, can you tell our viewers what is this again in a way that they understand? What is this SRS? Where is it used for? What it should be done? What they should look out for?
So basically, a single beam of radiation. It has to have very high energy to kill a particular tissue at a particular depth.
This is to treat brain tumors.
To treat brain tumors at depth.
Okay, at depth, without opening the skull.
Without opening the skull.
And no anesthesia.
No anesthesia. Since you want precision, you don't want the head to move, you fix a frame. But if there is one beam which is going, and there are multiple beams which go of lesser intensity, but all of them focus in one area, then that particular region receives phenomenal amount of radiation, which is enough to treat the tumor which is at depth.
And you burn the tumor.
You burn the
damage or whatever.
It's all about understanding the path these beams are going, the amount of radiation which is there in the tumor which is receiving, and the radiation spill in the surrounding normal structures. Are there any important structures there which are receiving radiation beyond their tolerance limits? So you modify all these structures to treat correctly only the tumor with least effects to the surrounding structures. And the accuracy of gamma knife is excellent.
I agree. Sub-millimeter.
Sub-millimeter.
Yeah, I agree with you.
So when I went, it had an old machine. By the time I left, it had got
the icon had come there. I remember that.
So I really worked hard for my entire stay in RR to get that icon machine there.
Fantastic. So what sir is saying is, neurosurgery, especially the brain, is probably the only specialty which has the highest number of non-cancerous tumors, which cause problems. You have a small bump on your hand, nobody cares. You have a bigger bump, nobody cares. But if you have even a 2 centimeter by 2 centimeter tumor, or even a peanut-sized tumor in the wrong location, it can create so much of problems. And sometimes going in operation, opening the skull is quite traumatic and high risk, and many parts of the brain is non-accessible, inaccessible or high risk. And he is saying that these things can now be burnt by radiation without opening the skull. Why? Because patients do not die because of this disease, because it's not like cancer, it spreads and you get. If you take care of it well, you can live for next 20, 30, 40 years. So SRS has been around for 60, 70 years. Now it's coming back in a big way again for the brain with the Zapex. Have you heard about the Zapex? Can you give a few things about what is this new technology that's coming?
Gamma knife uses cobalt 60.
Correct, the cobalt.
It's got a fixed half-life. It keeps decaying.
Correct. As the machine gets older, it takes longer to treat.
Zapex uses linear accelerator.
Got it. LINAC.
LINAC-based machine, which generates the radiation. So you need to switch on the machine, do some quality checks, and then it starts generating. Efficacy same. Both are equally efficacious. Both have sub-millimeter
Accuracy.
It's just the modality is different, and sky is the limit to what you can do with them. With the current machines which have come, you can target any part of the body with it.
Any part of the brain.
Any part of the brain.
Correct.
With gamma knife, you can go down.
This also.
Lower cervical spine.
Correct. This also you can go up to C4, C5, depending on the length of the neck that is there.
So, and it's really wonderful to.
It's futuristic, I think so. And Dr. John Adler is now talking about radio modulation for functional neurosurgery, especially in psychiatric disorders, functional neurosurgery for movement disorders. So I think we all should look forward to, doing SRS more actively, and, hopefully we should come up with some more announcement in the future as we go forward in this whole process. So next, before we wind up about, this whole thing, I want to talk to you about, I know how your life is in the army and the armed forces. What is your take? And you've heard this very sticky subject going on, work-life balance. And, every time, something happens, the Narayan Murthy said 70 hours per week. The L&T chairman said 80 hours per week. Don't look at your wife's face and something like that. And it became such a big issue. And this Gen Z, Gen X were, breathing down everybody's neck, and, they only want to work 40 hours a week. Their mental health is worse. That's besides the point. But what I'm trying to make out of, what's your take on work-life balance?
It's extremely essential to understand one basic concept. That work is not life.
What is it?
Work is not life.
Work is not life.
Work is a component of your life. We are playing different roles through the day. It's not actors who play a role. Every person is playing a role. You're a different person when you're at home. You're a different person when you're at work. You're a different person when you're with your colleagues in the evening. So each person, each position, each role requires a different version of you. Work is only part of your life. It's an important part of your life because it gives you purpose. It gives you financial independence to look after your family and everybody. And more importantly, it gives you a self-actualization to do something well. But all this is possible only if your home front is perfect, if your friend circle is good, because we are all social animals. We need that kind of connect. So your longevity depends on the kind of family you have and the kind of friends you have, along with your health. So if you neglect any of these, it affects the rest of it. So as you grow older, you need to stay healthy, not only for yourself, more importantly for your partner and for your family.
Healthy means mental health also.
Mental health, spiritual health, everything. So you need to understand that initially work may seem the only thing important in your life. But as you grow, you realize, as maturity sets in, The responsibility is all over. If a young fellow says, I am just starting and for me work is everything, he's got his parents to look after, he's got his sister to look after. So somebody or other is there intertwined in you with you. You need to strike a balance that you can give the maximum when you're doing your work, and at the same time give your maximum when you go home. So you need to balance out the entire thing. It is not the hours which are important. Quality of the work that you put in during those hours that are important.
I agree. I tell all my people, I said, including me, if you look around, at least couple of hours in a day will be wasting for something or the other, especially with social media now, it's getting worse than better. I think if you do not just hours, the quality of hours, because one, irrespective of your background, to this one, God has been very democratic with us. All of us have 24 hours in a day. Nobody has more or less. You can't buy the time. So I think how you use that time is what is going to be critical, for the outcomes to happen. So I think thank you for your take on work-life balance. I think Marshal, Dr. Sridhar, I think we had a great chat.
Thank you very much for inviting me. I'm honored.
My pleasure. My pleasure. Do you have any last messages to give the audience? Any take-home message that you want to give?
All I'm trying to say in Sanskrit is, as you think, you should speak. Yata chittam tata vacha. Yata chittam tata vacha. Yata vachas tata kriya. जैसे बोलते हो वैसे करो. As you talk, you do.
Correct. Your word should be a word.
यथा चित्तम तथा वाचा यथा वाचस तथा क्रिया. चित्ते वाचे क्रियायाम साधुनाम एक रूपता. The person who thinks something, says something and does the same thing is the one who is the correct person.
Brilliant. Simple. I think this should apply to everybody. I think then the world will be a very easy place to live, a more productive place to live, and a very happy place to live. Thank you very much. Jai Hind.
Jai Hind. Thank you. Jai Hind.
Jai Hind.
That's it.
So, Marshal Saab, there's a customary thing in our podcast to hand over a copy of the first book we have written called Rebooting the Brain. So, this is your copy. Please do read it and give me your feedback.
Definitely.
We've also written the second book called Neurojustice for the judiciary, but it's open to everybody because everybody can be a victim of road traffic accidents or falls. It's called Neurojustice. We have 4 volumes. Reach out to us, and if anybody wants a copy, you can definitely buy a copy from us. I know you have a copy of that. Please do give a feedback so we can apply this to the armed forces that is very passionate to you and see how we can help the disabled get better. Thank you very much.
Thank you very much.
And before we wind down, the housekeeping rules, please don't forget to subscribe to our channel, YouTube channel, Rebooting the Brain, Instagram and Facebook. And this time more importantly, because if you subscribe, you watch the video completely and you put your comments, you can get a copy of his a PowerPoint presentation of neck pain, back pain management. That's the carrot that we're giving you, because that will help to spread the word, and make sure that you spread this video and the reels to as many people as possible, because you never know who will benefit from neck pain, back pain treatments.